Alright, I welcome you guys back to another video lesson from ICU Advantage. For those of you who don't know me, my name is Eddie Watson, and my goal with this channel here is to try to give you guys the confidence to succeed in the ICU by taking these complex critical care subjects and making them easy to understand. I truly hope that I'm able to do just that. If I am, I do invite you to subscribe to the channel below. Make sure you hit that bell icon though, that way you never miss out when I release a new lesson. Alright, and this video is going to be a full collection of the entire 12-lead EKG series all in one video. You can think of this as a 12-lead EKG Masterclass, where it's a collection of all these lessons where you can just watch them all in one place. Throughout this video, I will link to each individual lesson if you do want to watch those, as well as the overall playlist where it has all these lessons in there as well, but for this video, this is just going to be one continuous run. Now that being said, if you really enjoy this video and you want to earn CE credits for it, this entire series is going to be up on ICU Advantage Academy here very soon. So make sure and head on over to icuadvantage.com/academy to be able to earn CE credits while you're watching these lessons, as well as have access to the notes that are available as well. So coronary circulation is responsible for ensuring that the heart has enough oxygen to meet its metabolic demands. Understanding the anatomy and physiology of this circulation is important, especially when it comes to evaluating EKGs, as well as understanding coronary artery disease and the interventions for that and myocardial infarction. So with that said, let's talk coronary circulation. Alright, so on to the coronary circulation. So the heart is a muscular pump that requires energy and oxygen in order to function properly. So we have our coronary blood supply, which is essentially the circulation of blood in the blood vessels of the heart. And as you know, there's two primary stages in our cardiac cycle. We have systole, which is obviously where the heart is contracting, and due to these muscle contraction, there's actually no perfusion that's going to be taking place to the heart here. Now in diastole, this is where we actually have the muscle relaxation of the heart. So here the aortic valve closes, and then we have retrograde flow of blood coming back down that ascending aorta. That's going to be stopped by those closed aortic valves, but then it's going to perfuse into the coronary arteries, thus going on to perfuse the heart. And so this is important to know because this is actually opposite of how all the other tissues in our body are perfused. They're normally perfused during systole, whereas because of that muscle contraction, the only way we have the opportunity to perfuse the heart is when it's relaxed, which is during diastole. Alright, so let's go ahead and start to talk about the anatomy of the coronary vessels. And so up here is an anterior and a posterior view of the heart that we're going to use throughout this lesson. So I do want to just quickly highlight some major structures that we have. So here we have our left atrium is going to be about here, although it's going to be kind of posterior on here. Here is going to be our right atrium, and then we have our right ventricle here, and then part of our left ventricle, which is going to be over here. Now you can also see we've got our superior vena cava, inferior vena cava, and our pulmonary arteries. And then we have our arching aorta here, which is going to come down to our aortic valve here. Running both directions from the aorta, we have our atrioventricular sulcus, or grooves, that are running basically the dividing line between our atria and our ventricles. Then running superior to inferior, we also have our interventricular sulcus, or grooves, and we have those both on the anterior here and the posterior surface here. And then looking at the anterior view, we've got our anterior lateral wall, our apex down here, and then our inferior wall. And then looking at our posterior view, again over on this side. And so here we have the anterior, lateral, and inferior wall, the posterior side of the heart. Again, our apex is down here. And once again, we have our inferior wall down here. Alright, so now that we have those major structures out of the way, let's begin to talk about our coronary arteries. So first and foremost, it's really important to know that everyone's anatomy is going to be different, and thus their coronary arteries can vary in their location, their size, and even the number of branches of a particular branch that we're going to talk about. I'm going to point out some of the big and common variations, but really know that there can often be many, many more of these. Alright, so to start off our coronary arteries, it's important to know that there are two main coronary arteries that come off the trunk of our ascending aorta, something that we refer to as the aortic root. So if we take a cross section of this section here and then kind of look down on the aortic valve, as if we're looking down through the aorta. We can see our semilunar aortic valve here. And then just above the aortic valve in the sinuses of Valsalva, we actually have our two coronary arteries that come off the aorta here, and then they're going to travel along those respective atrioventricular sulcuses or grooves, something also referred to as the coronary sulcus. So we have the right coronary ostium, which is where our right coronary artery is going to be coming off of, and then we have our left coronary ostium, which is where our left coronary artery is going to be coming off of. And then coming out from here, the coronary arteries do sit on the epicardial surface of the heart, so they're going to be directly under that pericardium. Alright, so now back to our diagrams here. Let's start talking about our left coronary artery, which, like I said, is branching off the left side of the aorta. And then we have the first small segment of this, which is something that we also refer to as the left main. Now, typically, the left coronary artery then bifurcates or divides into two main branches. First, coming down here, we have what we refer to as the left anterior descending artery, or the LAD. This is also sometimes called the left anterior interventricular artery. And this one travels inferior in that interventricular sulcus, hence the name of that anterior interventricular artery. And this is that groove that goes between our left and right ventricles on the anterior surface. Now, coming down the LAD, the first branch we have is actually our first septal perforator branch. And this is actually followed by many more septal branches coming off the LAD. And these are basically what perfuse the interventricular septum. Now, coming off on the other side, we start to have our first and then let's say our second diagonal branch here. And we're going to have at least two of these diagonal branches, but we can potentially have many more as well. And these are going to be going out and perfusing the anterior lateral segments of that left ventricle. Then the LAD is going to come down and wrap around the apex, and here it's going to be perfusing some distal apical segments. Now, the other bifurcation coming off the left coronary artery is actually going to be our left circumflex. This is sometimes abbreviated LCX. And this one gets its name because it wraps around the circumference of the heart. And so here it wraps around the left side of the heart, again in that atrioventricular groove. Now, coming off this, we are going to have the left atrial artery, and this is a small branch that comes off and, as you can guess, perfuses the left atrium. Then our first real branch is actually going to be our first obtuse marginal artery, so our OM1. This also goes by the name left marginal artery. Now, this one gets its name because if you remember from geometry, we had those acute and obtuse angles. The angle, when we're looking at this anterior view, we have an obtuse angle, hence the name obtuse marginal. Now, there can actually be numerous other obtuse marginal branches coming off the left circumflex. Typically, again, we're going to have at least two, the OM1 and the OM2, but like I said, there can be many more. Now, the higher or more proximal obtuse marginals are going to be perfusing more of the anterior lateral parts of the left ventricle, whereas those more distal obtuse marginals are going to be as that circumflex is wrapped around the posterior side of the heart, so these are going to be more inferior lateral and posterior. Now, like I said, typically the left coronary artery bifurcates into two branches, but in some small percentage of the population, we actually have a third branch that comes off. And this comes off actually in between both the circumflex and the LAD. And this, we give it its own separate name, and it's called the ramus. And this one basically serves the same purpose as those high obtuse marginal or high diagonal branches. So here it's going to be perfusing the anterior lateral wall. Alright, so now let's move on to the right side of the heart and let's talk about the right coronary artery. So this one obviously comes off the right side of the aorta, and this is going to be supplying the right side of the heart. And this includes the right atrium, right ventricle, as well as our SA and AV nodes. So the first branch that we have coming off the RCA here is actually going to be our conus artery. And this goes out to perfuse the RV outflow tract, as well as portions of the anterior RV wall. Interestingly, there is actually a study that suggests a decent percentage of the population actually has this artery as its own branch off the aortic root. Now, continuing along the right coronary artery, we have the sinoatrial nodal artery that comes off, and this is going to perfuse specifically that SA node. 60% of the people it comes off of the RCA here, Otherwise, the other percentage of people that this actually comes off the left circumflex. And then from there, we have our right atrial branch, which is, as you can guess, again, perfusing the right atrium. Then we have our first real big branch, and this is going to be our acute marginal artery, or also known as the right marginal. So again, we had the obtuse marginal on the other side. So here on this side, remember from geometry class, we've got that acute angle, that small angle, hence this is where it gets its name from. Now, here again with our acute marginal, we can have multiple branches of this, but these are going out to perfuse the right ventricle. Now, the right coronary artery continues to move along that AV sulcus, or that groove, and it's going to wrap around to the posterior side of the heart. And then we're going to have another important branch coming off here called the atrioventricular, or AV nodal artery. And as you guessed, once again, this one is a branch that goes and perfuses the AV node. And again, this is another one that may actually originate from the left circumflex in some small percentage of people. Now from here, the right coronary artery then bifurcates into two different arteries. We have the right posterior lateral artery, or the RPL, and this one is going to be perfusing the inferior lateral or the posterior lateral wall. And then heading inferiorly towards the apex, we then have the posterior descending artery, or the PDA. Now this one's also known as the posterior interventricular artery because again it travels inferiorly or posterior along that interventricular sulcus on the backside of the heart. And this one is going and perfusing the inferior and posterior wall of the heart, both the right and left ventricle. Now, this talking about the PDA actually brings us to an interesting discussion, something that's referred to as dominance. So we can have patients who are either right dominant, left dominant, or co-dominant, and really what this is referring to is where the PDA is coming off of. So in the majority of people, the PDA is actually going to be coming off the right coronary artery like we just talked about. So sometimes we'll refer to this as the RPDA. In a smaller percentage of people, we actually can have the PDA that comes off of the left circumflex as it wraps around posteriorly on the heart. Now, in these cases here, the right coronary artery then is really limited in some of the stuff that it's supplying, and that left coronary artery takes on a very big responsibility for perfusing a vast majority of the heart. And then in an even smaller percentage of the population, we can have something called co-dominance, and this is where the PDA is, we actually get the right coronary artery and the left coronary artery that come together in sort of an anastomosis, and then together form the PDA from there. Now, important to know that the coronary arteries do continue to branch further as they dive deeper into that myocardium, working their way towards the endocardium. This deep network of branches is actually something that we refer to as the microcirculation. And so this is where we have our perforator branches that go into our arterioles, which branch further into our capillaries. Now, these are unable to be seen on a coronary angiogram as they're really too small to be seen on there. While they are small in size, this microcirculation makes up the greatest portion of the coronary blood supply. And this microcirculation is what's primarily impacted by vasoactive mediators that produce both the vasodilation and the vasoconstriction. Alright, so now that we've talked about the coronary arteries, let's actually move on and talk about the coronary veins. So essentially, wherever there's going to be arteries, we're also going to have veins. Now, knowing these coronary veins is really not all that important, but it is pretty easy, so we're just going to review over it pretty quickly here. So to start things off, if we take a look at the posterior side of the heart, let's talk about the coronary sinus. And this is actually a large vessel. Like I said, it's located in the posterior part of the heart in that atrioventricular sulcus. And this is basically going to be a final collection point for several of these veins. And then from here, it's going to drain that deoxygenated blood back into the right atrium. All right, so first we're going to have our small cardiac vein. And this is going to be returning blood from the right side of the heart that's perfused by the acute marginal or right marginal artery. So it's going to come up along here. It's going to curve around to the posterior side of the heart along that sulcus, and that's going to join our coronary sinus. Now, next, if we stay looking at the posterior side of the heart, we have our middle cardiac vein. And this is going to be returning blood from the right ventricle that's perfused by the PDA. And so that's going to head up superiorly and again join our coronary sinus. Around here, we also have the posterior vein, which is going to run along near this middle cardiac vein. This is going to be returning blood from that posterior wall of the left and right ventricles, again perfused by the PDA, and once again that's going to come up and join the coronary sinus. Now, if we flip back to the anterior side of the heart, we have our great cardiac vein. So this is returning blood from the left side of the heart, all of that's being perfused by the LAD. So this is going to come up from the front of the heart, head up along the path of the LAD. It's going to join the right circumflex to wrap around the posterior side of the heart, where it then joins up and drains into the coronary sinus. And then lastly, for our veins, we have our anterior vein, and this one actually drains blood from the anterior portion of the right ventricle as well as the right atrium. Interestingly, this one actually does not join the coronary sinus, and this one drains directly into the right atrium itself. So all the other veins all link up together in that coronary sinus and then drain into the right atrium. The anterior vein, this one specifically, drains on its own into the right atrium. All right, and that is the anatomy of our coronary circulation from both our coronary arteries as well as our coronary veins. Knowing these, specifically arteries, is going to be really important as we get into talking in a little bit about our EKGs and some of the areas that are potentially being affected on what we see on that EKG. Before we do dive into that, though, the next lesson we're going to be talking about some of the physiology that's in play when we're looking at this coronary circulation, so make sure and stay tuned for that next lesson. In the last lesson, we talked about the anatomy of the coronary circulation and the vessels that play an important role in perfusing the heart. In this lesson, we're going to talk about why this blood flow is important and how it's regulated to ensure that there's enough to meet the demands of the heart. Now, to go along with knowing the vessel structure and the areas of the heart that they perfuse, we also should talk about the physiology that serves as the driving force behind how and why we meet the demands of the heart. So to begin this discussion, let's actually start talking about just blood flow in general. So the heart has the highest demand for oxygen than any other organ in the body. In fact, the heart has the highest A to VO2 difference, meaning that blood leaving the heart has a significant amount of oxygen that's used. Anywhere from 60 to 70% of the oxygen that makes it to the heart ultimately ends up being used up, and this is even at rest. As a result of this, the amount of blood that's delivered to the heart can actually be quite high. In general, about 5% of our cardiac output is specifically going to the heart. Now, at rest, the heart gets about 250 to 300 mLs per minute of blood, but once the demand increases, the blood also does rapidly and quite largely. So during exercise, we can see the blood flow increase to upwards of 1,000 to 2,000 milliliters per minute. Now, the microcirculation, which if you remember are those very small vessels that plunge deep into the myocardium, these are what are responsible for the changes that really regulate coronary blood flow. Now, I'll be talking more in depth about this in just a minute here. And then, as discussed in that lesson on the anatomy of the coronary circulation, remember that the heart is primarily being perfused during diastole. And the reason for this is that during systole, the heart is contracting, and thus the contraction of the cardiac muscle also constricts and squeezes the blood vessels of that microcirculation. So this not only leads to no flow, aka no perfusion, but it can also lead to some mild retrograde flow. Just an interesting point. Now that said, all of this is mostly true for the left side of the heart, so the areas perfused by the left coronary artery. Now both the right coronary artery and the left coronary artery are fed off the aorta, and thus they have the aortic pressure perfusing blood. Now the pressure in the left atrium, and especially the left ventricle during systole, prevent the forward flow of blood. These pressures then drop in diastole, and then the aortic pressure overcomes these pressures, and thus we have forward flow that's resumed. Now the right coronary artery is feeding the right side of the heart, and this is actually not diastole dependent. And this is because the aortic pressures exceed even the low pressures seen in our right heart. So this actually leads to a more uniform rate of flow of blood throughout the right coronary artery. Now, patients who have ischemic coronary artery disease that really has progressed slowly over time, that they can have a process called angiogenesis take place, and this is something that we also refer to as the formation of collateral circulation. So this is where new blood vessels are formed that run parallel to current stenosed vessels, thus increasing coronary blood supply and reducing coronary vascular resistance. Alright, so that's the basics of the blood flow. Let's move into something that we term active hyperemia. So the blood flow to the heart has a very tight relationship with the oxygen demand of the heart. When cardiac activity and thus oxygen consumption increases, the coronary blood flow also increases as well. This is something that we call active hyperemia. So the ventricular rate, the pressures, and the contractility all factor into the workload of the heart and thus the oxygen consumption. Now, because the heart at baseline extracts such a large percentage of the available oxygen, there's only a little room left to buffer any increased demand with the remaining oxygen that's left in the blood. This means that increasing blood flow is the primary way in which oxygen delivery can be increased to meet this increased demand. So a combination of downstream metabolites of oxygen consumption, along with local hypoxia causing the release of vasodilatory substances, are what are primarily responsible for this regulation and active hyperemia. Now, sympathetic and parasympathetic activations do also play a role in this process as well. So increased sympathetic activity leads to increased cardiac output and thus increased myocardial oxygen demand. Now, we do actually see some mild transient vasoconstriction here due to the alpha-1 activation on the blood vessels, and this would actually normally be counter to needing to increase myocardial blood and oxygen supply. This response, though, is short-lived, as the increased workload of the heart is going to trigger vasodilation via our active hyperemia. Again, I'm going to go more in depth into this in just a minute here, but this is a result of activating our beta-1 receptors of the heart, leading to the increased workload of the heart that we see. Now, when it comes to our parasympathetic, in our rest and digest mode, the workload of the heart is reduced. This is reducing the oxygen demand and thus the need for blood. Now again, initially, like with the sympathetic response, we do see an opposite reaction, as our vagal stimulation is going to lead to mild vasodilation of the coronary arteries, but the parasympathetic activity is typically going to lead to decreased activity of the heart, and thus this is going to reduce oxygen consumption, leading to a reduction of our vasodilatory mediators being released as a result of our active hyperemia. So this means vasoconstriction is going to take place, increasing our vascular resistance and thus decreasing blood flow, as it's no longer needed at this point. All right, and then lastly, let's talk about these vasoactive mediators. So now that we've talked about the process of increasing and decreasing blood flow based on the oxygen demand of the heart, let's talk a little about how all that works. So first we have oxygen and CO2. And simply, our local hypoxemia and hypercarbia do lead to vasodilation. Now that said, even with increased workloads, studies have actually shown that typically there's little change in coronary venous PO2 and PCO2. And so this tells us that the regulatory mechanisms work so well that generally a healthy heart can rapidly maintain these levels as the workload increases and decreases. Next is going to be adenosine. And adenosine actually plays a very important role in our active hyperemia and our autoregulation. So its formation is actually increased when hypoxia and increased oxygen consumption takes place through degradation of ATP. So if you think of the name, adenosine triphosphate. And this is even more so when there is an increase in oxygen demand that's really not satisfied by the oxygen supply. And so the presence of adenosine in the coronary vessels actually leads to vasodilation, and this is believed to be one of the stronger mediators in this process. Now, nitric oxide also plays an important role as a vasodilatory mediator, so it serves as a direct receptor-mediated vasodilator, and it also serves as an indirect vasodilator by inhibiting the effects of angiotensin II, as well as our sympathetic vasoconstriction. Now, nitric oxide is released by our vascular endothelium, and when it is diffused into vascular smooth muscle, it leads to increases in cyclic GMP, which ultimately causes smooth muscle relaxation and thus vasodilation. And then finally, we have endothelium. And endothelium is actually a potent vasoconstrictor, especially in the coronary vessels. Increased levels have actually been found in cases where the physiology would indicate a decreased myocardial oxygen demand. Therefore, we want to see that vasoconstriction to slow down the blood flow going to the heart because it's really no longer needed at that point. And so those are the different mediators that we know of. There are some other potential ones out there that are believed to play some roles, but these are kind of the major ones that I wanted to discuss here, and really overall to talk about the process of why that blood flow is important, how it's regulated, again, with that active hyperemia, how that all plays into increasing and decreasing the blood that's going to the heart based on the workload of the heart, the oxygen demand that's going on, because really the primary way that we drive increasing or decreasing the oxygen to the heart is by increasing or decreasing the blood flow. All right, in the last couple lessons, we focused on the coronary circulation, which is an important thing to understand, especially in the setting of our 12-lead EKG interpretation. Along with the blood supply to the heart, it's also really important to understand the conduction system, as without this, the heart really wouldn't be able to do the work that it needs to do. So in this lesson, we're going to dive into that here. Okay, so as mentioned when we were talking about our coronary blood supply, it is important to understand that our heart is a mechanical pump. Along with the necessary blood supply bringing oxygen and electrolytes that are vitally needed, there's also another important part that is what actually makes everything work. And this is the electrical conduction system. And that's what's really responsible for the spark that initiates contraction and thus the function of this mechanical pump. Without the functioning of this system, our heart would not be able to function properly, and thus blood would not make its way around the body. So speaking of the electrical conduction system, knowing the importance of this system for the function of the heart, hopefully you can understand why it's important to understand the components and how all this works. So our EKG, as we are going to discuss here soon, is only a measure of electrical activity and not any mechanical activity of the heart. Therefore, any changes on how the system is functioning not only are going to change how the heart works, but also change the appearance of the activity that we see on EKG. So our heart is made up of specialized cells or myocytes. Now we have many different types, but the main ones that we want to focus on here are the ones for pacemaking, signal transmission, and contraction. The purpose of these cells and the system is to generate the electrical activity that's going to lead to contraction of cardiac muscle cells, as well as to ensure that this activation signal reaches all the parts of the heart in an appropriate amount of time. And this system of cells exists throughout the myocardial tissue. So let's talk about the different components of this electrical conduction system. We'll walk through the parts of the system one by one, and I'll briefly describe the purpose of each one. So here, this is an internal view of the heart, which we're going to use to map out the pathway of this conduction system. So first off is going to be the sinoatrial node, or what we refer to as the SA node. So this is located in the right atrium, and this is near the junction with the superior vena cava. And this is the start of the electrical conduction system, and it's really the heart's main pacemaker. The activation of the SA node is what triggers atrial contraction to propagate from one atrial myocyte to the next. And it's important to know that we've got the fibrous tissue of the septum that's dividing both our left and our right side, as well as our atria and ventricles. This actually prevents the transmission of signal. And in about 60% of people, they have their SA node that's perfused by our right coronary artery. The rest of the people are mostly perfused by the left coronary artery, although there are some people that are supplied by both. Now next from here, we have something that we call Bachmann bundle. This is a specialized tract of cells that's responsible for carrying the signal from the SA node to the left atrium to ensure that really they're contracting together. This consists of high-speed transmission cells that travel from the SA node across the atrial septal wall to the left atrium. Now next we have our internodal pathways, and there's 3 different internodal pathways. We refer to them as the anterior, middle, and posterior, and these are primarily responsible for taking the signal from the SA node and passing it along to the AV node. So speaking of which, we have our atrioventricular node or the AV node. The AV node here is located again in the right atrium. This time it's near the coronary sinus and the tricuspid valve. This group of cells is specialized for the purpose of delaying the signal from the SA node briefly before sending it along to the ventricles. This delay is important as it's going to allow time for the atria to contract and thus completely fill the ventricles prior to their contraction. Now the AV node is exclusively supplied by the right coronary artery. Alright, next is something that we call the bundle of His, and this is another set of high-speed transmission cells that comes off the AV node. So this travels partially in the wall of the right atrium and then into the interventricular septum before it branches to the left and right ventricles. Now, in pathologically normal individuals, this is the only route of communication that exists between the atria and the ventricles. And the bundle of His eventually bifurcates into 2 branches. So the first one is going to be our right bundle branch, or RBB, and this is one of those 2 branches of bundle of His. So these high-speed transmission cells are what are responsible for carrying that signal to the right ventricle. The right bundle branch terminates into our Purkinje fibers, which we'll cover in just a second here. Now next we have our left bundle branch, or our LBB, and this is another branch off that bundle of His. As expected, this is another high-speed transmission fiber of cells that's responsible for carrying signal to fibers that will go to parts of the left ventricle. Now, due to the sheer size of the left ventricle, our left bundle branch actually divides into 2 more fibers to better cover the entire ventricle. So the first one we're going to talk about is the left posterior fascicle. This is actually the first branch off the left bundle branch, and this fiber actually has a fan-like appearance to it, and it's responsible for carrying the signal to the posterior and inferior portions of the left ventricle. Now, because of the wide distribution of this fiber that we see with that fan-like appearance, it's actually the most difficult one to develop a block in. Now from here, we have our left anterior fascicle, and this is the other branch of the left bundle branch. So this is a single-stranded fiber that sends signal to the anterior and superior parts of the left ventricle. And then finally, we have our Purkinje fibers, and these are actually coming off each of the bundle branches, and the fascicles are the cells that really connect with the myocytes. So you'll see them as just additional extensions coming off like our right bundle branch block here, as well as the left bundle branch when we're looking at the left anterior fascicle, as well as the left posterior fascicle, giving it really that fan-like appearance. These are what are responsible for initializing depolarization in the muscle cells, leading to contraction of the cardiac muscle. Again, like the atrial myocytes, the ventricular myocytes further propagate the signal to the other surrounding cells, just at a much slower speed than the high-speed bundles in the fascicles do. Alright, so that's the physical makeup of the electrical conduction system. One important aspect to know with the system is about the pacemaker ability of each of the different cells. So the pacemaking ability is really what dictates the heart rate that we see with our patient. Almost all parts that we just discussed of the conduction system have their own intrinsic pacemaker rate, which actually gets slower and slower as we move further down the system. And you can really think of this as the body's backup system. If a pacemaker higher up the chain fails to fire, after enough time has passed, a lower level pacemaker will fire to ensure that a contraction still takes place. As mentioned, the SA node is the primary pacemaker of the heart, and it has an intrinsic rate of 60 to 100 beats per minute. Now, the SA node also responds and adjusts its rate based on the needs of the body. Now, next we have the AV node, which actually has an intrinsic rate of 45 to 50 beats per minute. Then the bundle of His and the bundle branches each have a backup rate of 40 to 45 beats per minute. And then finally, the Purkinje cells and the ventricular myocytes themselves have a backup rate of around 20 to 40. Obviously, the slower rates of the system more distal to the SA node are either not ideal or in some cases life-threatening. They can buy the body time to correct itself or us more time to try and fix them. All right, so from here, I wanted to move on and talk about the electrophysiology of this system. I really wanted to just quickly describe the process of depolarization and repolarization of these cells to give you a better understanding of what's happening here. There are many electrolytes that play a vital role in this process, and therefore the alteration in the levels of these electrolytes can and often do affect the function of the heart. The main electrolytes that play a role in this process are sodium, potassium, calcium, and chloride, although magnesium can also impact things as well. So we have our muscle cells here that we can see that are connected in these long fibers called myofibrils. The collection of these myofibrils are what make up muscle fibers, and then collections of those obviously make up our muscles. Within each muscle cell, though, we have strands of this myosin and actin, which when activated with the help of calcium, the strands move along one another, causing contraction of the cell. As these cells and the cells of these myofibrils all contract, they decrease in size, leading to the contraction that we see. So then from here, it's important to understand about cell polarity. So the fluid inside the myocyte consists of a different concentration of ions than what exists outside the cell. Naturally, the concentration of ions wants to balance out across a semi-permeable membrane, aka our cell membrane. These cells, though, have a specialized pump, something that we call the sodium-potassium pump, that works to help to keep this in balance. So it actually pumps 3 sodium ions out of the cell while bringing 2 potassium ions in, all with the help of ATP. So by doing this, we're moving more positive ions out than we're bringing back in, so it actually creates a relatively negative environment inside the cell, consisting of a higher level of potassium, while outside the cell it consists of a higher level of sodium. This actually gives the cell a resting potential of around -70 to -90 millivolts. Now, as time passes, ions, mainly sodium from outside the cell, are actually going to leak into the cell, making it less and less negative. We can actually see this represented with the phases of an action potential, which I'm going to graph out for you here. And this is called phase 4 of the action potential. And here you can see the slow rise of the polarity of the cell from that resting potential. Now, once the polarity has increased to a certain threshold level, a specialized set of channels open up, something that we call fast sodium channels. So this is really a one-way channel that's going to allow sodium, a positive ion, to quickly enter into the cell, rapidly rising the charge of the cell, eventually matching the outside polarity, something that we call depolarization. And this is what we actually consider phase 0 with our action potential that you can see here with the sharp rise up. And again, this depolarization is then transmitted from cell to cell until they are all depolarized. Now, when the cell reaches its peak charge, or it's really maximally depolarized, the sodium influx is going to be slowed down, and then we're going to start to have a leak of negatively charged chloride ions that are leaking into the cell as well. This slowdown actually leads to the closing of those fast sodium channels, and then opening of 2 other channels that we call the slow sodium channels and the calcium channels. This is what we see as a small drop from the peak, something that we call phase 1 of the action potential here. Now, next, as the sodium is slowly entering and we have this influx of calcium, we really kind of maintain a relatively flat polarity, something that's known as the plateau phase or phase 2 that we see on the action potential here. Now, remember that calcium plays a vital role in the ability of myosin and actin to bind, and thus this is where the physical contraction is really beginning. Also, the more calcium that's available, the stronger and the longer the contraction that we're going to see. Now, from here, we start to have some potassium channels that are going to open, and this is going to allow potassium, which is at a higher concentration in the cell, to actually leave the cell, leading to a fairly quick drop in the polarity of the cell. You can see that here on our graph of the action potential, and this is what we refer to as phase 3. So this eventually leads to a negative charge again for the cell, effectively repolarizing it. Once we get back to that resting potential, so again, -70 to -90 millivolts, once that's reached again, at this point, all the channels will have been closed, and then we have our sodium-potassium pump that goes back to work, and this process starts all over again with that slow increase of phase 4. Now, the speed at which phase 4 creeps back up is fastest within the SA node myocytes, and then gets slower and slower the more distal we go in the conduction system. This is what leads to the slowing of that intrinsic or backup rate that we see. So this was a lot of information that we covered pretty quickly here, but it definitely is vital to understanding this conduction system from its parts to how it all works, as it is going to directly impact the function of the heart and then ultimately what we observe with our EKG. Understanding these changes that you see and what they mean are really going to be important in recognizing what's going on and, more importantly, giving us the information we need to treat our patient. Alright, so now that we've discussed the coronary circulation and reviewed the electrical system of the heart and how it works, it's now time to move into actually learning about our 12-lead EKG. The coronary circulation and the conduction system will come into play when evaluating our 12 leads, but we need to start off with some introductory information first to establish a good foundation of knowledge as we move into the actual interpretation, so let's discuss that here. Alright, so this is going to be a series of lessons taking a good look at our 12-lead EKGs. I'm going to break the lessons up into multiple lessons on various aspects of our 12-lead interpretation. I am going to cover a lot of information here in this series, but also know that this series is not going to be going super in-depth. We're going to cover information that's mostly pertinent for your evaluation and interpretation working in the ICU, but know that there's definitely much more to learn beyond what's presented here. At the end of this series, you should have a good understanding of what's happening with our 12-lead, as well as have the knowledge needed to evaluate what is shown for our most common concerns. So to start things off, let's do a quick review over the basic components of our EKG waveform. Here we have an example of a single waveform for a complete cardiac cycle. This essentially tells us about the electrical activity of the heart. So first we have our isoelectric line, and this is the baseline of our EKG tracing. This really represents no electrical activity. Now we have our P wave here, which is going to be our atrial depolarization. Then we have our QRS complex here, which is our ventricular depolarization. And then finally we have our T wave, which is our ventricular repolarization. And we do actually have atrial repolarization that takes place, but it is pretty minimal on our tracing and it is buried within the QRS complex, and thus it's not something that we typically see. Now from here we have certain intervals and segments that play an important role in getting measurements for. The first one is going to be our PR interval. This is measured from the start of the P wave to the start of the QRS complex, and this tells us the time from atrial depolarization until ventricular depolarization. Then we have the width of our QRS complex, measured from the beginning of the Q to the end of the S, and this tells us the time it took for the ventricle to depolarize. Then we have our QT interval, and this is going to be measured from the start of the QRS complex to the end of the T wave, and this is the time it takes for both ventricular depolarization and repolarization to take place. And then finally we have our ST segment. This segment here represents when the ventricles are depolarized with no electrical movement taking place before repolarization. And this should be along the isoelectric line like we see here. Alright, with that out of the way, let's move on and talk about the EKG system and really give you the understanding of the different parts and how it all works. So first we have our electrodes, and these are what measure the electrical signals. These are the little stickies that we put on the patient. And then from there, we hook up the wires or the different leads to those electrodes. So we have positive and negative leads, something we call bipolar, which can, go figure, be both positive or negative depending how we're using them, as well as a series of positive leads. Now this is important because the direction of electricity in relation to where the positive lead is determines how we're going to see a waveform. So let me kind of give you some examples and show you this here. So if we have electrical activity that's moving towards a positive electrode, then we're going to see a positive or upright waveform. Now, if this electricity is moving away from a positive electrode, then this is when we're going to see a negative or downward waveform. And then if the electrical activity is actually traveling perpendicular or alongside the positive electrode, then this is when we get a biphasic waveform. So if it's perfectly perpendicular, we're going to have this equiphasic or isoelectric waveform, so our positive and negatives are going to be the same. But then as we start to shift the angle and either going more towards or more away, that this can actually change how the waveform appears, and we can have smaller positive with a larger negative or a larger positive with a smaller negative, and that kind of determines how we see our waveforms. Now, for the electrode placement, it's really important that in order to have accuracy of our EKG recording, we have to have proper electrode placement or lead placement. So the improper positioning here is going to change the appearance of the waveform, and this can either mask issues that we have or falsely present other ones. So for our preparation, ideally, a patient's hair should be clipped, the site should be cleaned with alcohol, and we should use skin prep. This is going to greatly reduce the amount of artifact that's present. Understandably, though, time may not really allow for this. We do want to elevate the head to around 30 degrees for the patient, again if possible, and then we do want to try to keep the chest bare, so we don't want to have sheets, blankets, gowns, clothing over the top of the electrodes. That said, it's also important that we keep the patient warm, because if they're shivering and moving, that this is going to introduce artifact as well. So the patient's going to want to be still. Now for the actual placement of these electrodes, there's only 10 physical electrodes that we're going to be placing, but these together are going to give us our 12 leads that we're viewing. So here we have our patient's body, and let's go through the different lead placement that we have. First is our right arm lead, typically the white lead in our typical 5-lead bundle. And this one's going to go on the right arm, distal to the shoulder. Next we have the right leg lead, again typically our green lead. This one's going to go on the right leg distal to the hip, although typically we try to put this below the knee. Next we have the left arm. This is going to be the black lead. This will go on the left arm distal to the shoulder there. Then we have the left leg or the red lead going on that left leg distal to the hip, again typically below the knee. Next is going to be our V1 lead. This is typically the brown lead on that 5-lead bundle. And the positioning for this is going to go 4th intercostal space on the patient's right sternal border. Now for V2, this is also going to be 4th intercostal space, but this is going to be just across the sternum on that left sternal border. Now for the remaining V leads, it's helpful if we place V4 and V6 first, because these are actually going to be reference points for V3 and V5. So V4 is going to go now the 5th intercostal space, but this is going to be mid-clavicular line. Then for V6, this is going to be mid-axillary, so along the patient's left side, but we want to make sure that we have this along the same horizontal plane as V4, so at the same level as V4. Now going back to V3, that this one we're going to place midway between V2 and V4, and then V5 we're going to place midway between V4 and V6. Again, important that we're along that same plane as those other leads. Important to stress, it's important that V4, V5, and V6 are in a line along that horizontal plane. Alright, so now that we have the properly placed leads, we do need to understand about the different views that we get from these leads. So let's talk about the plane that I've been talking about, these different planes. Really, we can think of planes as ways to divide the body. I always imagine this like a magician who cuts a person in half. The blade of the magician would be one of the planes. And there's 3 primary anatomical planes. We have the vertical or frontal plane, and so this is dividing the body into anterior or posterior or front to back. So think of this one as running head to toe, dividing the body into the front and back. Next we have the axial or horizontal or transverse plane, and this divides the body into inferior and superior, so top and bottom. To help visualize this one, this would be the same plane that the magician magically cuts a person in half. And then finally we have the sagittal plane, and this one divides the body into left and right. So again, head to toe, but this time left and right instead of front to back. Now of these 3 planes, the 2 that we really care about for our EKGs are the vertical frontal plane, so dividing front and back, and the axial horizontal plane, dividing top and bottom. Half of our leads that we have are going to be looking at the heart in the vertical frontal plane, and the other half will be looking at the heart in the axial horizontal plane. So when it comes to these actual leads, we have different groups of leads that we have. So the first is going to be our limb leads, and these are going to be leads 1, 2, and 3. These 3 leads are looking at the heart along that vertical frontal plane, and lead 1, we're going to have the positive electrode on our left arm, and we're going to be looking from the right arm to the left arm. For lead 2, that this is going to be looking to the left leg from the right arm. And then lead 3 is also going to be looking at the left leg, this time from the left arm. Then we have our 3 augmented limb leads. These are the remaining 3 leads that are still looking at the heart along that vertical frontal plane. And we can really think of the augmented limb leads as being the average view between 2 different leads. So first we have AVR, R being right. This is going to be looking at the right arm, but combining the view from the left arm and left leg. So you can kind of think here, if we look at this, if we draw a line between the left arm and left leg, and then the midway point of that to the right arm is how we're looking. Now for AVL, this is left. So here we're going to be looking at the left arm, but combining the look from the right arm and the left leg. And then finally AVF, where the F stands for foot, is going to be combining the look from the right arm and the left arm down to the left leg. And the purpose of these augmented limb leads is they give us a different angle of view from the traditional limb leads. The more angles we have, the more perspective we have on the heart. And to really kind of put all this into perspective, if we take an image of the heart here, and let's draw a circle and divide it up so we have different angles of our views, we can see if we look at lead 2 on our body here, going from the right arm to the left leg, that angle, when we put it up against the heart here, coming down at about 60 degrees, this one's roughly about the same direction that we would expect the electricity to be traveling in the left ventricle. And then from there, you can just look at the direction that we're looking at things at the different of the 6 leads, and then put those angles onto sort of our pie chart that we have here. All right, so from there, let's talk about our precordial or our chest leads. These are going to be V1 through V6. And these 6 leads are now looking at the heart from the other important plane, the axial or transverse or horizontal plane. So this is that plane dividing the body from top to bottom. These leads give us a good look at the area of the chest over the heart and really give us a more complete view of the heart. So if we take a cross section here across the horizontal plane, we can see we've got the heart here, we've got V1 through V6 along the chest here. Now, each of these leads, though, is the equivalent to measuring from a theoretically calculated reference point. This is something that we call Wilson Central Terminal, and we're going to go from that, which is located about here in the heart, out to each one of these precordial leads. The way that it does this is it gets the calculation by utilizing the 3 limb leads, so right arm, left leg. These 3 combine to make a triangle, and then the middle of this triangle is this Wilson Central Terminal. All right, so now let's talk about artifact. So if you're having artifact in your tracing, you really need to correct this issue to ensure that we do get a good clean picture when we're evaluating our EKG. If you have artifact in any of the limb leads, you can usually determine which electrode is the culprit by evaluating 2 different leads. Typically, we're going to have artifact in 2 leads if one of the limb lead electrodes is the problem. So if we think about the leads that are involved in getting the particular recordings where we were drawing out earlier, if we're seeing artifact in leads 1 and lead 2, we want to check the right arm because that's typically going to be the electrode that's causing the problem. If we're seeing artifact in leads 1 and 3, the left arm is typically the culprit. And if we're seeing artifact in leads 2 and leads 3, then the left leg is typically going to be our culprit here. Correcting the artifact in these limb leads are also thus going to correct any artifact that we see in the augmented limb leads because they're using the same electrodes. So first you want to fix any limb lead artifact first, then you can move on to the precordial leads. And these ones are actually easy to fix because you can easily identify which lead is the culprit. If V3 is showing artifact, then fix the V3 electrode. Alright, so now let's move on and talk about our EKG paper. And this is essentially a standardized background that we have for our 12-lead EKG to print out on, and this is both on paper and electronic versions. The standardization of this allows us to compare between different EKGs of the same patient as well as between patients, and it helps us draw conclusions based on the size and position of the waveforms. So now let's actually talk about the 12 leads that are going to print on this paper. So again, remember we've got our positive, negative, and biphasic that we talked about. Positive is going to be above the isoelectric line, meaning the electrical activity is moving toward the lead that we're viewing. Negative is going to be below that isoelectric line, meaning electrical activity is moving away from the lead that it's viewing. And then biphasic, being both above and below, means electrical activity is partially moving towards and then partially moving away from the viewing lead. And this applies to our P wave, our QRS complex, as well as our T wave. And then depending on the lead and the direction of the wave that we see in that lead can actually tell us a lot about many different things. And these are going to be things that I discuss more later in this series. So looking at our paper here, we have our limb leads on the left and our precordial leads on the right. We typically are going to see 3 per column, and thus the first 2 columns here on the left are our limb leads, with the first column being our normal limb leads, so 1, 2, and 3, with the next column being our augmented limb leads, AVR, AVL, AVF. The next 2 columns are the precordial leads, and they just go in numbered order, so V1, V2, V3, and then V4, V5, V6. Then at the bottom, we're going to have our rhythm lead, and this is going to run full length across the bottom. Now, typically this is lead 2, but this is something that we can change in the settings, as well as sometimes we can have multiple full-length rhythms showing across the bottom. Typically, we're going to have time marker hashes either at the bottom or the top of the paper. The total length of this full rhythm strip, though, is 10 seconds. So we should have 2 3-second marks and a 4-second mark. And these marks, as well as the boxes that we see, the big and small boxes, as well as just knowing the total here being 10 seconds, that these all help us to determine the rate of our patient's rhythm. So remember, 25 millimeters, so 5 big boxes, is equal to 1 second of time, moving left to right. So speaking of that, let's talk about the paper size and the measurements that we get. So our standardized EKG paper also has a standardized speed at which it prints, and that is the 25 millimeters or 5 big boxes per second. The standardization also takes place for the voltage measured of the electrical activity. So this is shown as the amplitude or the height of the wave going either up or down. And here, 10 millimeters, so 2 big boxes, is going to be equal to 1 millivolt. All right, and so then for the boxes themselves, we have both our large or big boxes as well as our little boxes. A large big box is composed of 5 little boxes, each little box measuring 1 millimeter by 1 millimeter, giving us, for a big box, 5 millimeters by 5 millimeters. And so here the height is going to be equal to the amplitude or voltage. And remember that I said 2 big boxes is 1 millivolt. Thus 1 big box is going to be a half of a millivolt. Then the width of the big box is going to be time, so how long the electrical activity is taking place. And remember I said 5 big boxes is 1 second. So take that 1, divide by 5. 1 big box is equal to 0.2 seconds. And then for those little boxes, we know that there's 5 of those within each big box. So for the height of a little box is going to be equal to 0.1 millivolt, and the width of a little box is going to be 0.04 seconds. And again, for these, we just took the values from a big box and divided it by 5 to get these values. Now at the top of our paper, we're usually going to have some more information here. The top left is typically going to be our patient information. The top middle, we're going to get calculated values for our different measurements. So the rate, the PR interval, the QRS complex width, etc., as well as our axes, which I am going to be going over all of this more in the next lesson and future lessons. Then at the top right, we're usually going to have our computer's interpretation, as well as once it's been manually reviewed, the reviewer can make annotations or changes for their own interpretation. Again, this is going to come later in the series. And then finally, I want to talk quickly about the relationship between the leads and the heart regions. And we do this through something that we call contiguous leads. And what this means is that we have leads that are looking at the same part of the heart. And I'm going to go through and group them out and divide them up and use different colors to really show the groupings. But really, you're just going to need to memorize this pattern that I'm going to show you. This way, when you're looking at a printout of the EKG, you know the different regions that we're looking at. So first, let's actually start down in the bottom corner here. So leads 2, 3, and AVF. I'm going to highlight these in green, and these are going to be the inferior portion of the heart. Then we have leads 1 and AVL here. that these are going to represent the high lateral. Then we have V1 and V2 that are going to be our septal leads, V3 and V4 anterior leads, and V5 and V6 low lateral. Now that said, when we're looking at our precordial leads, we're really going to also consider any two leads that are near each other also being contiguous. And the reason for this is if you think about that cross section I showed you with those leads going across there, even though like if we look at V4, we consider that anterior, and V5, we consider that low lateral, they're actually pretty close together, so they're looking at a similar part of the heart. And really one of the big purposes for memorizing and knowing this is that when we're looking at especially patients who are having MIs, if we know what vessels from the coronary circulation feed what regions of the heart, we can then see if we see changes here in particular leads, we would know what part of the heart is impacted, and thus generally which blood vessel is involved in this. Again, this is stuff that I'm going to go more in depth in a future lesson, but I just wanted to kind of cover the basics and give you an understanding of what that meant. All right, so we covered a lot of information here for our introduction to doing our 12-lead EKG interpretation. Knowing this information is really going to build that solid foundation for the future lessons in this series and are really going to help bring it all together and help it to make sense for you. This is going to give you the why for when we're going through these future lessons, and we're just talking about the changes that we see. Referring back to this lesson here will give you that why on why things might be looking different. In the last lesson, we covered the foundational information about our 12-lead EKG. Having that understanding out of the way, we can now move into the actual interpretation of the EKG itself. I'm going to break down the various aspects of interpretation into really several videos to be able to cover each part in more detail, but in this lesson, we're going to review over the overall steps that are involved in our 12-lead EKG interpretation. Alright, so this lesson here is going to be an overview of each of the steps of the 12-lead EKG interpretation. So when we get started with reading EKGs, it's really important that you identify some sort of systematic approach that works for you and that you can go through each and every time. Now, really the purpose of this is to ensure that you're going through each EKG thoroughly and that you really don't want to miss any of the steps. There's a lot going on with our 12-lead EKG and there's a lot for you to evaluate, so I really want to make sure that you don't get lost in all this information. Now, more advanced practitioners are not necessarily going to follow a step-by-step process, but they've done them more than enough that they really know what they're looking for and they're not going to miss any of those parts. That said, it's really best to find a systematic approach for yourself, and at least for some period of time initially, you want to religiously stick to it. This way, you're going to ensure that you're evaluating every part of the EKG that you should be. Now, all that said, as time goes on, certain obvious things will begin to stick out to you, but other than some circumstances where you need to make a quick decision, such as if you're giving nitro for a patient that has chest pain, etc., you're really going to want to stick to this systematic approach, this stepwise approach. Now, there are many different approaches that I've seen, and they all cover the same information, just in different ways of going about it. So here, I'm simply going to be presenting one approach that I found helpful. Alright, so into our 12-lead EKG interpretation. So as we go through the steps of our EKG interpretation, we're going to use a normal EKG for this process. So right here is actually an example of a normal EKG that we're going to primarily use throughout this particular lesson. So it is important that you see normal. Knowing normal is going to help you identify when something isn't normal. And particularly in the ICU, we're seeing sick people, elderly people, and they just aren't completely normal. So it's really helpful to be able to recognize a good normal EKG. All right, so to start things off, we've got our first step, which is going to be our rhythm analysis. So for this step, it's going to be expected that you've got a good understanding of basic rhythm interpretation. So I'm really not going to be covering that in this lesson here. I will actually link to a series of lessons that I've already put together covering all these different topics, all the blocks and all the different rhythms that you're going to need to know. Watch that lesson if you certainly aren't comfortable with that stuff. But when it comes to our rhythm analysis, first we want to actually determine the regularity. So we want to determine if the rhythm is regular, regularly irregular, or irregularly irregular. If we have consistent intervals between our R waves, then we obviously have a regular rhythm. One of the easiest ways to check for this is if you got a piece of paper, put the paper on the EKG, make marks on 2 of the successive R waves, and then just move that paper along and see if those R waves just march right out. Also, just at a quick glance, oftentimes an irregular rhythm is really going to stand out, and you'll really be able to see the differences in the R to R intervals. So here's actually a quick example of an EKG of a patient who's in AFib, and as you can see here, especially if we look down at the rhythm strip across the bottom, it's pretty clear that we've got some pretty inconsistent R to R intervals. Now, keep in mind that just because our patient's rhythm is regular, it does not mean that the rhythm is normal necessarily. We can actually see regular rhythms with a flutter, third-degree heart block, junctional and ventricular rhythms, just to name a few. Now, if the rhythm is not regular, but we do see a consistent pattern to some of this irregularity, then this is what we refer to as regularly irregular. So some examples of this would be things like potentially atrial flutter sometimes, second-degree type 1 heart block, so our Winky block, as well as bigeminy and trigeminy. These are going to be irregular, but there's going to be some sort of regular pattern to this irregularity of R to R intervals. Now, if the rhythm is not regular and there's really no discernible pattern and the QRSs just seem to randomly appear at different intervals, then this is what we refer to as irregularly irregular. So some examples here would be our sinus arrhythmia, atrial fibrillation, atrial flutter can sometimes present this way, multifocal atrial tachycardia, and this is really where we have multiple areas of the atria that are firing, as well as our second degree type 2 heart blocks. Now, from there, once we determine the regularity, we actually want to move on and look at the rate. So we need to evaluate the rate of our patient's rhythm. Are they tachycardic, bradycardic, or normal? So remember our normal heart rate, 60 to 100 beats per minute. And so actually if you look at the top of our 12-lead EKG, right here the computer is actually going to show us a heart rate. But we also want to confirm everything that the computer tells us. This includes all of our other measurements, any interpretation. We want to confirm all of that with our own eyes and basically determine whether or not we agree with what it's saying. The computer is certainly great at giving us a lot of good information, but it sometimes can be inaccurate or just not sure of exactly what it's seeing. So there's several methods that we can use to evaluate a patient's heart rate. So the first one is we have our big box method, and this is probably the quickest and most preferred method, at least for our regular rhythms, but it does require a little bit of memorization or basic math. So with this method, what we're going to see is how many big boxes present between R waves. So first we need to find an R wave that lines up with one of our big boxes. So here's one here, so let's actually zoom in and take a little bit of a closer look at this one. So we know from our previous lesson that a big box is 0.2 seconds. Thus, it takes 5 of these big boxes to be 1 second. So if we kind of think about this, if we had a beat that was every 1 second, then in 1 minute we'd have 60 beats since we have 60 seconds in a minute, thus giving us a heart rate of 60 beats per minute. So knowing this, we know that 1 second is 5 big boxes, so if the next beat that comes along aligns with the 5th big box, we know that we have a heart rate of 60. So we can actually use this math to extrapolate out for all the other 0.2 second intervals, so each big box, and we come up with the following scale. So basically this is from 1 big box, 2 big boxes, 3 big boxes, etc. And so if the next R wave that were to come along were to fall on either the first big box or then the second big box, we would have the following heart rates: 300, 150, 100, 75, here's that 60, 50, 42, etc. So this is something that you can just train to memory, and then this way you can just look at an EKG, align these boxes, and then figure out what our patient's heart rate is. If you don't want to memorize, you can also do just a little bit of math. Essentially, you just take 300 and divide it by the number of big boxes. It really comes out to be the same thing. So to use this big box method, all we need to do is determine how many big boxes are between the R wave that we identify that falls on the line and then the next R wave. So in our example here, we can see that the next R wave is just before the fourth big box. We know that 4 big boxes would give us a heart rate of 75, so we know that we're just faster than 75. And as we can see, the computer here says 77, so we agree with this and we know that it's correct. All right, the next method beyond the big box method is to either look at a 6 or 10 second strip. So remember that the bottom of our 12 lead EKG has our rhythm lead that runs the full length. There may or may not be hash marks. If there are, they're going to give us 2 3-second intervals, so a 6-second strip as well as a final 4-second interval. This then gives us a total strip of 10 seconds. If there are no hash marks, then we just know that this total strip is still 10 seconds. So what we can do here is we can count the number of QRS complexes in either a 6-second interval and multiply that by 10 to get our heart rate, or we can count the total number of QRS complexes across the whole rhythm strip, so our 10-second strip, and then multiply that by 6 to get our heart rate. Now this one takes a little bit of time, but it's not too much more. And important to know that this is the method that we want to use if we have an irregular rhythm. So again, if we take a look at our EKG of the patient in AFib, so if we count across the bottom here, we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. We have 18 QRS complexes. We then multiply that number by 6, giving us a rate of 108. So now that we've evaluated the regularity as well as the rate of our patient's rhythm, we now want to determine whether we have a narrow or wide QRS. So again, remember that a normal here is going to be less than 0.12 seconds or 3 small boxes. So some common causes of having a wide QRS complex result from things like bundle branch blocks, beats that are originating in the ventricles, left ventricle hypertrophy, as well as pacemakers. There are some other less common causes, such as various drugs, especially some of our antiarrhythmics, our Wolff-Parkinson-White pattern, as well as profound hypokalemia. Again, in our example here, it's a little hard to tell, but we are less than 3 boxes, a little bit over 2. And here we can see the computer is telling us that the QRS is 0.084 seconds, and 2 small boxes is 0.08 seconds. So again, we also agree with this here. All right, now we want to move on and evaluate atrial activity. So first off, we want to see if we have P waves that are present. If not, we want to evaluate for fib or flutter waves. Now, if we do have P waves that are present, we want to look at our PR interval. Normal for this is going to be 0.12 to 0.2 seconds or 3 to 5 little boxes. We also want to evaluate, is the PR interval consistent or is it changing? And do we have 1 P wave for every QRS complex? If we don't, is there any association that's present between our P waves and our QRS complexes? So again, in our example here, as you can see, we do have a P wave for each of our QRS complexes. And if we look at this particular one here, we have about 4 small boxes from the start of the P wave to the start of the QRS complex. 4 small boxes equals 0.16 seconds. And once again, if we look up top, the computer is telling us it's 0.162 seconds. So again, we also agree with this. Now then, we also want to look at the size of our P waves and determine, are they similar morphology, as well as if there's any atrial enlargement, which I may actually do a separate lesson on, just covering some of these atrial changes. Again, in our example here, all the P waves look the same in each respective lead. And so finally, after going through all of these steps, with all the above information that we gathered, having the knowledge of the different rhythms that you should expect to see and be expected to know, you should be able to make a determination of the actual rhythm that's seen. So in our normal example here, we obviously have a normal sinus rhythm, which again, here the computer has also determined at the top, which once again, we can also agree with. All right, now moving on to step 2, here is where we're going to be looking at the QRS axis and morphology. So for our next step, we're going to want to evaluate both the cardiac axis as well as the morphology of our different QRS complexes. So let's start off talking about axis determination. And this is the part of the 12-lead EKG interpretation where people's eyes tend to just gloss over or they get that deer in the headlights look. I'm actually going to do a whole separate lesson on this in much more detail, but it's really not that difficult of a concept to understand, I think, if it's explained properly. So basically, our axis is the average direction in which electrical activity flows through the heart when we're looking at the patient in that vertical or frontal plane. So we know if we look at our patient in their heart that the general direction for electrical activity is to flow down and towards the patient left, our right when we're looking at it. We have different parts of the heart depolarizing going in different directions, but if we average all these different directions of all of this electrical activity, and also with the left ventricle being the largest, we get an average direction. So this is generally from the patient's right shoulder to their left leg direction, which, if you remember, correlates with lead 2. So remember from that last lesson that we're going to see a positive waveform if we're moving towards a positive electrode, thus we expect to see lead 2 positive. So knowing that, we can look at the direction of electrical activity in relation to various leads to try and determine if we see positive, negative, or biphasic waveforms on our EKG tracing. Then we can actually use this knowledge to determine the direction of our patient's electrical activity, aka their axis. So if we look at particular leads in a normal heart with normal electrical conduction, we would expect to see positive QRSs in leads 1, 2, and 3. Again, in our example here, we do have positive QRS complexes in each of these leads. So there are several methods to determine this axis, which I am going to discuss in that lesson specifically covering all this. Essentially, we can take a circle, draw out different quadrants to represent the different axes, and we can think of these quadrants as the average direction of electrical activity. So in the bottom right, from 0 to 90 degrees, we have our normal axis. And just looking at this, we can see if we place this over our heart, this aligns with the direction we expect electrical activity to flow. Now above that, from 0 to negative 90, we have our left axis deviation. Although from 0 to negative 30, the first part here, we actually consider this non-pathologic. And again, I'll cover this more in the future lesson. Then in the bottom left, from 90 to 180 degrees, we have our right axis deviation. And then finally, top left, from negative 180 to negative 90, we have our extreme axis deviation. So there are different etiologies that our patient can have that deviate or shift this axis either left or right, which we want to be able to identify on the EKG for further evaluation. Again, this is all going to be covered in this lesson on axis determination. So for our example here, the computer gives us a QRS axis of 54 degrees, which, looking at our quadrants, we know is in that 0 to 90 degree quadrant, making this a normal axis, which we also confirmed seeing positive leads in 1, 2, and 3. Again, I know this probably sounds like a lot, but I promise it's going to make much more sense after that particular lesson on this topic. Alright, so after determining the axis, we then want to evaluate the QRS morphology, as this can really tell us a lot here. So first, if they have a wide QRS, we really want to determine the cause. Is this a bundle branch block or some other conduction delay? I'm also going to be doing a whole separate lesson on bundle branch blocks and how we identify those. But we also want to look for pathologic Q waves, and these are going to be Q waves that are present where we shouldn't see them, or in ways that are not to be expected, such as wider or deeper than normal. These are often a sign of prior or old MIs, and they usually take several hours or days to develop. Unless quickly revascularized, once they appear, they're typically not going to go away. Now, I'm really not going to cover this much in this lesson here, as this gets a bit deeper into EKG interpretation than I really wish to go here. But certainly feel free to look more into this, as it will help to further your knowledge of EKG interpretation. Now here we also want to look for evidence of either left ventricle hypertrophy or right ventricle hypertrophy. Again, this is going to be another separate lesson that I'm going to do, but essentially we're looking for enlarged QRS complexes in particular leads that can be an indication of enlarged ventricles. We also want to evaluate low voltage. And this would be small QRS complexes across the whole EKG. And this is actually caused by conditions that would limit the conduction of cardiac electrical activity to the surface of the skin, which is where we measure it. This is typically caused by either fat, fluid, or air. Here's just a quick example of a low voltage EKG. As you can see, the waveforms are really not showing very big or defined, and we're seeing this pretty much across the whole EKG. So some of our common causes that we see for this are going to be things like obesity, where here we've got fat that's getting in the way, COPD, this is going to be air that's interfering with this conduction, either pleural or pericardial effusions, this would be fluid, as well as myocardial infiltration, again, another source of fluid that's going to potentially block that electrical activity, that conduction of electricity from going all the way out to the skin. Electrical alternans is another thing to look for. So this is actually an alternating axis of the QRS complex, which is usually the result of a large pericardial effusion. You can actually see this quite clearly in this example here, and you can see this by the markedly different QRS complexes and the alternating pattern that you see. We've got a large one, a small one, a large one, a small one, and so on. And then finally, we want to look for the presence of something that we call a delta wave. So here's a good example of delta waves. So as you can see with a clear example here, a delta wave is actually a slow, shallow upstroke of the QRS complex. Typically, this is going to lead to having a wide QRS complex and a short PR interval, both of which present in the example that I've got for you here. And this is a classic Wolff-Parkinson-White pattern. So this is where we actually have an accessory pathway that bypasses our AV node, and thus we get ventricular depolarization starting, not originating from that signal coming down those bundle branches. All right, so from here, moving on to step 3, what we're going to be looking at here is our ST segment, T-wave abnormalities, and our QT interval. So we want to take a look at a few more areas that really could show us important information on this EKG. So first, we're going to evaluate our patient's ST segment. And when we're evaluating this ST segment, first and foremost in our mind is that we're looking for possible signs of ischemia or infarction. There are other things that can actually cause these changes, but when we think about the biggest risk to our patient, this is going to be at the top of that list. And in fact, we actually have a whole list of things that we call STEMI Mimics that come about that could mimic some of the ST segment changes that would really make us think ischemia or infarction, but in fact are not. So again, I'm going to be doing a whole separate lesson on this topic of ST elevated myocardial infarction, and in that lesson we're going to go into much more detail on all this, but just know that in this step, this is where we want to be looking for this. So for our ST elevation, we need to evaluate all 12 leads for any signs of ST segment elevation, and this is where that ST segment does not return to the baseline isoelectric line. So here's an example of this here. In this example, we have a lateral MI with good ST elevation in leads 1, AVL, as well as in V5 and a little bit in V6. And these are going to be all of our lateral leads. But you'll also notice that we do have reciprocal changes where we see ST depression in leads 2, 3, AVF, as well as V1 through V3 we see some. And so when we measure this ST elevation, trying to determine, if we have enough elevation, we do this from something that we call the J point, which is the point right here at the end of the QRS complex. So if we have an elevation above that isoelectric line of 1 millimeter, so one small box, in any 2 contiguous leads, with the exception of V2 and V3, then this is what we would consider ST elevation. So it doesn't take much for us to classify something as ST elevation. Now that said, for leads V2 and V3, instead of 1 millimeter, we actually need to see 2 millimeters. So just some of our potential causes real quickly for now for ST elevation can include things like obviously STEMI, left ventricular hypertrophy can do this, left bundle branch block, paced rhythms, Benign early repolarization can present this way. Pericarditis, left ventricular aneurysm, coronary vessel vasospasms, as well as severe hyperkalemia, hypothermia, PEs, Brugada syndrome, and Takotsubo cardiomyopathy. Now, we already kind of hit on this a little bit, but in addition to ST elevation, we also want to be looking for ST depression. So here, unlike elevation, we're looking for an ST segment, again measured from the J point, that's below the isoelectric line. So for this, anything that's 0.5 millimeters or more, so half of a small box, and we have this in 2 contiguous leads, that we would then consider this to be ST depression. So some potential causes of ST depression include our non-STEMI. Again, this is going to be the top of our list for concern. Potentially a posterior MI. We might see this when we're looking at our normal anterior view. We're going to see this initially as ST depression in particular leads. Reciprocal changes like we just talked about in the presence of a STEMI in other leads. Left bundle branch block can also do this. Left ventricle hypertrophy with strain pattern can look this way. Digoxin toxicity, hypokalemia, as well as tachycardia can all present with ST depression. All right, so now we've evaluated our ST segment. Next, we want to evaluate our patient's T wave for any abnormalities. So there's actually a lot that could be covered here as well, but for the basics of this, really we want to be looking for a T wave inversion and for peaked T waves. So T wave inversion. This is where we have a T wave that has a negative deflection that's greater than 1 millimeter, so one small box. If we have this isolated to either leads 3, AVR, and V1, that this is something that we actually consider normal. As you can see from our example here, we have isolated T-wave inversion in AVR, which, like I just said, is something we consider normal. Anything outside of these 3 leads, we would consider true pathologic T-wave inversion, and some potential causes of this, all of the same causes of ST depression, as well as elevated ICPs, hypothyroidism, as well as late pericarditis can all present with these pathologic T-wave inversions. Then we also want to look for peaked T-waves. And when we're talking about peak T-waves, we're looking for enlarged T-waves that are typically the size of the QRS complex or larger. So here's an example of some here, particularly if we look at V2 through V5. If we have this going on and we have a narrow base with a tall symmetrical peak, then this is actually most likely going to be the result of hyperkalemia. If you remember that memory mnemonic of hyperkalemia, we're looking for peak T waves, we're going to see this with a narrow base, tall symmetrical peak. In our example here, that's actually what we see. Now, if we do have peak T waves, but we've got a wide base and we've got an upsloping or asymmetrical peak, that this could actually be the sign of early STEMI before we begin to see those ST elevation changes, as well as we can also see T waves that look like this with vasospasm. All right, so after evaluating our T waves, finally we want to evaluate our patient's QT interval. And this is going to be the start of the QRS complex to the end of the T wave. This raw measurement, though, doesn't actually tell us a lot, as our patient's QT interval is often going to change based on their heart rate. So faster heart rates are going to have shorter QT intervals, and so really what we need to do is correct the QT interval for the heart rate, something that we refer to as QTC or QT corrected. So this is done in a few different ways, and as we can see here, the EKG actually does the calculation for us as well. One quick rule of thumb when we're evaluating our patient's QT is to take 2 consecutive R waves and then find the halfway point between them. The halfway point is going to be a QT corrected or QTC of 500 milliseconds. The preceding T wave should conclude before this halfway point. So a normal QTC for men is actually considered to be less than 450 milliseconds and less than 460 milliseconds for women. That said, generally, Greater than 500 milliseconds is really when many consider this to be clinically significant, and thus our general eyeball rule of thumb is good for evaluating this. The big concern that we have for an elevated or enlonged QT interval is that the patient is at risk for R on T, so this is where we have a QRS complex that falls on a still depolarizing ventricle, a T wave, and this could lead to torsades, as well as the patient being at risk for long QT sudden death. So potential causes for our prolonged QT, this include things like our congenital long QT syndrome, hypothermia. Various medications can prolong this. This includes certain antiarrhythmics, antibiotics, antidepressants, antiemetics, as well as antipsychotics. So think of a lot of our antis in here, that these potentially have medications that can also prolong this QT interval, as well as we can see this with hypokalemia, hypocalcemia, hypomagnesemia, as well as hypothyroidism. So again, here think of all of our hypos. These are all potentially things that could lead to prolonging this QT interval. All right, so having done that, we have gone through all the different steps and looked at all the different parts of the EKG. Now, obviously, we went through some of this stuff real quickly here. Like I said, I'm going to have on some of this stuff, actually a lot of this stuff, I'm going to have individual lessons where we can break this down in more detail. But this is the general overview process that you want to go through. So again, this is just one example of one systematic approach. The important thing is that you find one approach that works for you and that you stick with it, religiously go through each and every step when you're evaluating an EKG. This way, when you're going through, you're not going to miss a single thing. So I really hope this was good information for you guys. Make sure and stay tuned for those future lessons where I'm going to dive even deeper into these different topics. So hopefully that by the end of this entire series, you guys should be pretty comfortable when it comes to looking and evaluating your patient's 12-lead EKG that you get in the ICU. So again, my goal isn't to make you as competent as a cardiologist. That's certainly not expected nor even needed. But it is important that you're able to look at this and quickly see some things, confirm with what the EKG is telling us as well, and be able to get people's attention to that quickly when needed. All right, now that we've reviewed over the basics of our 12-lead EKG, including the steps to go through when evaluating one, I do want to dive a little deeper into a few different topics that I mentioned in that last lesson. The first of these is going to be understanding about and looking for the bundle branch blocks, which we'll discuss now. All right, when we're talking about the bundle branch blocks, we're talking about defects in part of the electrical conduction system of the heart. In order to understand what's happening, let's take a look at the mechanisms that are at play with these blocks by looking at a diagram of the heart. So again, remember that conduction typically starts with our SA node and then is transmitted to the AV node, which after its delay, the signal is then conducted down the bundle of His and then to the right and left bundle branches. Also remember that our left bundle branch quickly then branches into both our left posterior fascicle and our left anterior fascicle. And so these bundle branches here, this is where we are having our problem. What is happening, as the name suggests, is that either the bundle branch or the fascicles are becoming blocked and really no longer can conduct the electrical signal appropriately. And this is the result of injury to these bundle branches or fascicles, oftentimes from underlying heart disease or myocardial infarction. So when we have healthy functioning bundle branches, the electrical conduction is quickly moved throughout the ventricles out into those Purkinje fibers, which connect to the cardiac myocytes, and then thus leads to rapid depolarization of the ventricles, causing that quick, synchronized, forceful contraction. Once we block one of these branches, the affected areas of the heart really are no longer receiving the conduction quickly. So, for example, if we were to block the right bundle branch, then the right ventricle is not going to quickly depolarize, while the left ventricle is still going to be rapidly depolarizing. As the left ventricle depolarizes, it's going to pass this depolarization along to the rest of the heart via those ion channels, those gap junctions going cell to cell, which will eventually and slowly depolarize the right ventricle. So all of this results in a loss of the synchrony of those ventricles, along with that prolonged depolarization, both of which can actually contribute to a drop in cardiac output. So now let's talk about the electrophysiology of what's happening and really what we expect to see with our 12 lead. So again, if we take a look at our heart here, you'll remember that we have our 6 chest leads, V1 through V6, which are really looking at the heart across that horizontal plane. Of these leads, we have V1, which is going to be our most rightward lead in relation to the patient's heart, and then the most leftward lead is going to be V6. And these are going to be the most important leads for us to look at and to understand the changes that we'd expect to see. So looking at the heart from V1 and V6, let's start off looking at what we'd expect to see with normal conduction in the heart. So here we're evaluating our QRS complex, as this is what is our ventricular depolarization. So to start things off, as the electrical signal is passed from the AV node down the bundle of His into the left and right bundle branches, the first thing that we're going to see is actually going to be septal depolarization. So this normally results from a small branch off the left bundle branch, and then this propagates in a left to right direction. Now again, remember from that previous lesson on the introductory concepts of our 12 lead, that if the electrical conduction is moving towards our positive lead, that we would then see a positive waveform, and if it's moving away, we're going to see that negative waveform. So knowing this, with this initial left to right depolarization of the septum, this is going to be moving to the right side, so towards V1, we would see a small positive deflection to start here. On the other hand, when we're looking at V6, this conduction is now moving away, therefore we'd expect to see this small negative deflection to start. Now from here, we still have rapid transmission of the electrical signal down normal healthy bundle branches, which then quickly makes it through the Purkinje fibers and into the ventricles, rapidly depolarizing both the left and right ventricles. Now again, remember we have signals moving in many different directions, but our mean electrical direction due to the size of that left ventricle is going to be leftward. So when we're looking at V1, this means that the electrical activity is going to be moving mostly away from this lead, leading to that large negative deflection in our tracing. On the other hand, when we're looking at V6, now the electrical activity is moving towards this lead, giving us a large positive deflection. Now with both of these, once the heart is fully depolarized, we're going to see that rapid return to the baseline isoelectric line. So looking at these two leads with normal electrical conduction, these are the patterns that we would expect to see. Now let's actually take a look at how this changes with our blocks. Do keep in mind that for the next couple sections, we're going to talk through what's happening and what we expect to see. That I'm going to use illustrations that I do here of kind of what we would expect to see with our leads. But as you're going to see in a little bit with some example EKGs, the exact morphology will look slightly different from EKG to EKG. Alright, so now let's take a look at what happens when we have a right bundle branch block. So things now begin to change both in how our electrical conduction and depolarization takes place, as well as how we're going to see that represented on our 12 lead. So now walking through this example here, we have this block in the right bundle branch, and so the signal is not going to be moving down here. So starting out, we have our septum, which is still depolarized normally from the properly functioning left bundle branch, and this is going to be again in that left to right direction. In V1, we again see that initial small positive deflection as the signal moves in that direction. In V6, since this conduction is moving away, we'd expect to see a small negative deflection, but for some reason with right bundle branch block, this often doesn't actually show. So then from there, we then have the left ventricle, which is going to begin rapidly depolarizing first. Here again, most of the electrical activity is going to be going towards the left. So this actually gives us an initial negative deflection in V1, and then a positive deflection in V6. Now following this, that wave of depolarization is going to be slowly moving across the right ventricle, and then this is going to lead to large electrical activity on the right, but it's also going to be slower, which on our 12 lead, time is represented moving side to side. Therefore, in V1, with this electrical activity moving towards this lead slowly, we're then going to see another positive deflection this time with a much wider than normal complex. So this actually gives us our classical appearance of a right bundle branch block in V1, which is characterized by something that sometimes is referred to as either rabbit ears or M shape. So you can see with our two R waves that this is where we get that appearance from. Either looks like a pair of rabbit ears or it just gives us that M shape to it. Now looking at V6, here with the electrical activity moving away, we're going to see a negative Y deflection. And then finally, we need to talk about our T wave. So with right bundle branch block, it's actually normal for us to have a T wave that's going to go in the opposite direction of the terminal wave of our QRS complex. So this is something that we refer to as T wave discordance. And again, this is going to be normal in our bundle branch blocks. So here in V1, since our terminal wave is positive, we would then see a negatively deflected T wave. Thus in V6, since our terminal wave is negative, here we should be seeing a positive deflection of our T wave. So this should be clear in a little bit when we take a look over some example EKGs. Keep in mind that because of the changes that we see with the right bundle branch block, that this actually mimics other pathological changes that we can see, and thus a right bundle branch block actually limits our ability to diagnose right ventricular hypertrophy, which I will be discussing in a future lesson. Alright, so now on the other side, if we have our left bundle branch that is blocked, we're going to see things change differently. So here, that intraventricular septum is normally depolarized from the left bundle branch, but since it's blocked here, this means that it's either going to be depolarized in a right to left fashion, or normally left to right at a later point. So we may see early right to left depolarization and thus a small negative deflection in V1 and a small positive deflection in V6, but in reality, typically these aren't present with our 12 lead with a left bundle branch block. Moving on, so now we still have the right ventricle that's going to be rapidly depolarized, while at the same time, this much larger left ventricle is going to be slowly depolarized. So this tends to lead to the mean electrical activity being slow and towards the left. So thus what we see is a large wide negative deflection in V1, so as we're moving away to the left, and a large positive deflection in V6 as we're moving towards that lead. And then finally, again, just like with our right bundle branch block, we are going to see that T wave discordance. So along with the T wave discordance, we're also going to see a shift in our J point. So what this means is that the J point and the T wave deflection are going to be shifted away from the majority of the QRS complex. So for example, when we're looking at V1, we have our complex with a large negative deflection. We're going to see the J point actually shifted the opposite direction, thus positive above the isoelectric line with a then positively deflected T wave. And as you can see, this actually mimics ST elevation. Then in V6, we have a large positive deflection with our complex, so we're going to see that J point shifted negative of that isoelectric line with a negatively deflected T wave. Again, this here can also appear as ST depression. So just like with the right bundle branch block, this shifted J point and T wave discordance will also be present with other pathologies and can impede our diagnosis of either left ventricular hypertrophy as well as our STEMI. To help differentiate STEMI from other pathologies that do have this shifting J point and T wave discordance, have something that we call Sgarbossa's criteria, which is actually something I'm going to further discuss in the future lesson talking about STEMI and our 12 lead. Alright, so now that we have the basics of the changes we'd see with our bundle branch blocks on our EKG tracing, let's actually talk about how we identify and diagnose these. So essentially, the anatomical location of the defect to the conduction system is going to be how we determine and classify the blocks as either right bundle branch block or left bundle branch block. The left bundle branch can further be divided into those fascicles, and sometimes we can have just one of the fascicles blocked as opposed to both of them being blocked, or the left bundle branch as a whole, but these are going to be beyond the scope of this series that I'm doing here. So in order to truly diagnose a bundle branch block, we need to have a wide QRS complex. So this means greater than 0.12 seconds or 3 small boxes. So we can have incomplete bundle branch blocks that have a bundle branch block morphology, but our QRS complex is less than 0.12 seconds. But again, this is going to be beyond the scope of this series here. So once we have identified a wide QRS complex, we want to look at the morphology of this complex in V1. So here we're going to evaluate the large terminal wave. Remember that this lead is on the right side of the heart, and thus if we have a large positive terminal wave, that this would be indicative of a right bundle branch block. If this terminal wave is negative, this means we're moving away from this electrode and thus would be indicative of a left bundle branch block. So the easiest way to remember this is to think of the turn signal on your vehicle. So whatever direction your terminal wave is, so think up positive or down negative, think about what direction you would be going if you hit your turn signal that way. If you hit your turn signal up, you're going to be turning right, thus a right bundle branch block. If you hit it down, you're going to be turning left, thus a left bundle branch block. All right, so then from there, we should expect to see the opposite in V6 with the terminal wave, as again, this lead is now on the other side of the heart. Also keep in mind that our lateral leads 1 and AVL, also have a very similar direction that we're looking at when we look at V6, and so they're also going to present with these similar morphologies that we'd see with V6. With all of this said, there certainly are further characteristics that are used to really properly evaluate and diagnose these bundle branch blocks, but again, this is going to go deeper into 12 leads than I think is necessary for this basic interpretation series. All right, so now let's quickly talk about our bundle branch blocks and show some examples as well. So to start, let's talk about our right bundle branch blocks, and some of the potential causes of right bundle branch blocks can include things like right ventricular hypertrophy, pulmonary hypertension, or cor pulmonale, acute pulmonary embolism, PE can do this, ischemic heart disease, congenital heart disease, myocarditis, as well as cardiomyopathy can all potentially lead to a right bundle branch block. Now also, most people, the right bundle branch block is perfused by the left anterior descending artery, and thus they may manifest with blockage of this artery. All right, so now let's take a look at a couple examples of 12 leads. So here is our first example here, and let's start things off by measuring our QRS duration. So some of these leads, it is hard to tell if the QRS is actually wider than 0.12 seconds or 3 small boxes. But if we do look at V2, I think it's clear that we're somewhere between 3 to 4 small boxes, making this a wide QRS. Now we want to take a look at V1. Here we can see that we have that classic rabbit ears or M shape that's typical with a right bundle branch block. In addition, our terminal wave is positive or up, which if we're using our turn signal and flip it up, we're turning right, thus a right bundle branch block. We also have the appropriate T-wave discordance with an opposite negative deflected T-wave. And then finally, if we look at V6, as well as our other lateral leads, 1 and AVL, we'll see that we have our terminal deflection negative, opposite of our positive terminal deflection seen in V1. All right, so let's take a look at another example. And here in this example, again, some of the leads are hard to tell, but especially when we're looking at V1, it is clear that our QRS is greater than 0.12 seconds or 3 small boxes. So further evaluating V1, we again have that classic rabbit ears or M shape with that terminal wave deflected up or positive, along with that discordant negative T-wave deflection. Thus, using our turn signal method, we know we're turning right, thus a right bundle branch block. And again, finally, our terminal wave in V6 as well as 1 in AVL are deflected negatively, opposite of what we have in V1. All right, so now let's talk a little bit about our left bundle branch blocks. And some of the causes here would include things like aortic stenosis, ischemic heart disease, hypertension, dilated cardiomyopathy, as well as hyperkalemia and digoxin toxicity, that these can all lead to a left bundle branch block. The left bundle branch is also perfused by primarily the LAD, but also times in part by the RCA, and thus blockages in either of these can also potentially manifest in left bundle branch blocks. All right, so again, let's take a look at a couple of examples. Here in this first example, if we look at our QRS, I think it's much more clear here that we do have a wide QRS greater than 0.12 seconds. So we then move on and take a look at morphology in V1. and as we can see, we've got this large negative terminal deflection. Using our turn signal method, flipping the turn signal down means we're turning left, thus this is our left bundle branch block morphology. We also note a positively shifted J-point, so going opposite of that negative deflection, as well as that positively deflected T-wave, both of these mimicking that ST elevation. And then finally, looking at V6, we can see we have the opposite with the large positive terminal wave, negative J-point shifting, and negative T-wave discordance. All right, one more example. In this example here, again, looking at our QRS, I think it's quite clear that we're greater than 0.12 seconds. Switching over and looking at V1, we see we've got that deep, wide, negative terminal deflection. The turn signal method tells us we're turning left, thus left bundle branch block morphology. Again, we see that positive J-point shifting and positive T-wave discordance opposite of that terminal negative deflection. And then finally, looking at V6, it's really not very clear, so we can evaluate our other lateral leads, 1 and AVL. Things are a little clearer here, but certainly better with AVL. Here we now have that positive terminal wave, opposite of V1, with negatively shifted J-point and negative T-wave discordance. All right, and those are our bundle branch blocks and the basics of kind of what's going on with those, which when you kind of think about that and think about those lead placements, kind of makes sense with how those changes are going to manifest on our 12-lead EKG, as well as just some general points of when you're looking at these EKGs, how you can quickly evaluate through and determine, do we have a wide QRS? If so, do we have a bundle branch present based on that morphology in V1, as well as the opposite taking place in those lateral leads? So I really hope that I was able to explain this information in a way that makes sense for you guys and that you can carry this forward and evaluate those 12 leads and determine if you have right or left bundle branch blocks that are taking place. The concept of axis deviation is one that oftentimes goes over people's heads, or when it comes up in discussion, people tend to get that deer in the headlights look. While this certainly can be a complex topic in discussion, the basics of what it is, how we determine it, and what it all means is pretty straightforward. If it's explained properly, it should be pretty easy to understand this topic, so I'm going to attempt to do that in this lesson here. So I'll start off things saying that as a bedside nurse in the ICU, it's certainly not going to be critical that you're able to take a 12-lead EKG and do the calculations to determine the cardiac axis. That said, it is important for you to understand what this all means, and more importantly, what physiological conditions would alter it. And truth be told, the process to roughly determine the cardiac axis on an EKG is pretty fast and easy, and it doesn't hurt to know how to do this pretty quickly. This is only going to give you a more intimate understanding of the EKG and allow you to confirm what the computer tells us on the paper. Before we get into determining these cardiac axes, let's actually review over some concepts that play an important role in this process. I did discuss these in previous lessons, but it'll be helpful to refresh that here and apply it to what we're doing. So first, we're going to be talking about vectors, aka the direction of electrical activity. So remember that if we have a positive electrode, that this is where we're looking from. Think of a camera that's on the positive electrode looking towards the negative electrode. If the electrical activity is moving directly towards this camera, aka positive lead, then we would see a completely positive waveform. On the flip side, if the electrical activity is moving directly away from our lead, then we're going to see a completely negative waveform. Now, if this electrical activity happens to move perfectly alongside or perpendicular to this lead, then we would see it going both towards and then away, giving us a waveform that is both positive and negative, and equally so. So these are the basic concepts of how these waveforms will look. But sometimes, in fact more often, the electrical activity is not going to be moving directly towards or directly away from a lead, but generally at some angle to it. So for example here, if we have it coming down towards the lead but off at a, let's say, 45-degree angle, we would see a mostly positive wave still, but we would also see some negative deflection to this waveform. The same goes if it's moving away at an angle. We are going to see mostly negative waveform, but with some positive direction as well. Alright, now let's talk about the cardiac axis and really what this means. So remember that when our heart depolarizes here, we have electrical activity that's taking place going in all sorts of different directions. So there's really millions of cardiac myocytes all facing in all sorts of directions. Some of them will be facing and thus depolarizing in the same direction, while others will be going in other directions. Our cardiac axis is the total average of all of these directions combined together. Remember that this is generally going from the patient's right arm to left leg direction or down into the patient's left. The left ventricle is by far the largest part of the heart, and thus, due to its size, it tends to overpower this average, which is why we see this as our normal. Now, later in this lesson, I will discuss this next concept here a bit more, but we have various pathologies that can cause this average direction of electrical activity to shift or deviate from this expected normal path. If someone has an enlarged heart or an enlarged ventricle, this can start to pull the electrical activity towards this larger area. If part of the heart has infarcted, then we would not see electrical activity in that area, and thus it would push or shift the direction away from this area. So changes in the function of the conduction system will also shift this direction depending on what's happening or if certain routes are blocked, such as with our bundle branch blocks that we just talked about. I am going to discuss these more in a later lesson, but just know that for various reasons, this cardiac axis isn't always going to be normal. And then finally, for our foundations here, let's talk about our limb leads. So conceptually, knowing the cardiac axis is the direction that we expect electrical activity to flow, how do we even determine this? Well, remember that we just discussed that we could determine what direction electrical activity is moving in relation to a positive electrode based on the morphology of the waveform. Thus, we can look at various leads, and knowing the directions that they're looking, as well as their morphology, that we can actually determine this. So to understand how we're going to do this in just a minute here, we need to also review over these leads real quickly. So for the purpose of this lesson, we're only going to be looking at the limb leads, so leads 1, 2, and 3, AVR, AVL, and AVF. So remember from that lesson a while ago that we're utilizing the right arm, and left leg electrodes to get these different limb lead views. So first, looking at leads 1, 2, and 3, we have the 3 electrodes that basically form a triangle on the body. While this isn't a perfect triangle, we actually have something that we call Einthoven's law, and again, this isn't important for you to memorize, but just good to know. But basically, this law says that we can think of this triangle actually as an electrically equal triangle. Thus, we can actually place these leads around our heart. And we know that lead 1 goes from right arm to left arm along the top here. Lead 2 goes from the right arm to the left leg along the side here. And lead 3 goes from the left arm to the left leg along the side here. Thus, these 3 leads are looking at the heart and its electrical activity in 3 different directions, which for simplicity's sake we can draw out here. Lead 1 is directly to the patient's left, while lead 2 is down and to the left, and then lead 3 is down and to the right. And again, that these are going towards the positive electrode, and therefore any electrical activity moving these directions would be positive. But we can also have this activity moving away, and so it could also be negative along this same line. And so for simplicity's sake, we can take a circle, divide it up into sections, with each of these sections being a direction that these leads are looking, such as positive lead 1, negative lead 1, positive lead 2, negative lead 2, positive lead 3, and negative lead 3. Alright, so now let's talk about AVR, AVL, and AVF. So these 3 limb leads basically are calculations that go from the middle of this triangle out to those respective electrodes. So to the right arm, we've got AVR, to the left arm, we've got AVL, and to the left leg, we've got AVF. So if we draw that out here, we can see that we again have 3 lines going out to a positive electrode like before, but now these are 3 more different directions. Again, this electrical activity can be moving either towards or positive, or away and negative, and thus we can also take these direction lines and use those to further divide up our circle that we just did with the other 3 leads. Alright, so now if we take this divided circle and take a closer look at it, we can set directions for all of these lines. So what this means is that we consider the positive direction of lead 1 to be 0 degrees. And if we move down, we have our positive degrees in 30-degree increments going all the way up to 180. Then moving along the top of the circle, we have our negative degrees, again in that 30-degree increment, going all the way to 180 degrees negative. So this divided circle here with these positive and negative directions of leads and the degrees of each line is something that we actually call the hexaxial reference system, and this is going to come into play here shortly in determining what our patient's cardiac axis is within 30 degrees. If you remember from before though, looking at this circle with the degrees, it kind of reminds us of the quadrants that I talked about. If we take a look at our 4 quadrants, we have this section being our normal axis, this here being our left axis deviation, this quadrant being the right axis deviation, and then this quadrant being our extreme axis deviation. We can then superimpose this over our hexaxial reference system, and remembering that I did mention that 0 to negative 30 degrees as being what we consider non-pathological left axis deviation, thus making it a part of our normal axis, we can now see how this hexaxial reference system can be used to determine not only the degree of our cardiac axis, but what we would consider it, whether it normal, left deviated, right deviated, or extreme deviation. Alright, so now on to our cardiac axis determination. So we've covered a lot of theory behind the concepts of the cardiac axis. This is important to help you understand what this all means and why it is that we're able to even know what the axis is. Now let's actually talk about the practical application of this hexaxial reference system and how we apply it to our 12-lead EKG. So we'll start out again with our normal EKG here. So the first step to this process is to take a look at our 6 limb leads, and we want to find the isoelectric lead. So we're looking for the lead that has the electrical activity that's moving alongside it or perpendicular to it, which is represented by that isoelectric waveform. So this lead isn't always going to be perfectly isoelectric, so it might be slightly more positive, slightly more negative, but of the 6 leads, it's typically going to be the smallest or the lowest voltage lead. You may have 2 leads that are close, but you want to make a determination of the most isoelectric. Again, also the smallest lead. So in our example with this EKG here, this is actually going to be AVL. And you can see that this one is pretty close to being perfectly isoelectric. It's pretty equal positive and negative, and it's definitely the lowest voltage. So then for step 2, now that we've identified the isoelectric lead, we then want to determine the perpendicular lead. So the perpendicular lead is going to be the lead that the electrical activity is mostly moving towards or away from. And this can be either positive or negative. Every lead has its own perpendicular lead, which conceptually, if we take a look at our hexaxial reference system, we can see that for each lead or line that's on here, there's another lead that intersects it perfectly perpendicular at 90 degrees. This is the perpendicular lead. So for our example here, if we look at AVL on our hexaxial reference system, let's highlight that in blue here. The perpendicular line to this is the one here in red, which is going to be lead 2. Now we can also just memorize this picture of our limb leads on an EKG with arrows showing the perpendicular leads. In the middle we have 2 in AVL going straight across. Then we do these diagonal lines for 1 in AVF being perpendicular and 3 in AVR being perpendicular. This is pretty easy to memorize and makes determining the perpendicular lead quick and easy. Again, following this method on our normal EKG, our isoelectric lead is AVL, and therefore we know straight across is our perpendicular lead, lead 2. Alright, for step 3, now that we know the perpendicular lead, we need to determine is the waveform in that lead positive or negative. Pretty simple, and in our example here we can see that we have a positive waveform in lead 2. Having this information, we then go back to our hexaxial reference system and look for the lead 2 line and go to the positive end. As we can see, this is going to be in the left inferior quadrant down here, and this is going to be at the 60-degree mark. We can also see that it's within the normal axis, which we'd expect with a normal EKG here. Again, we can compare this to the computer's interpretation, which has the QRS axis at 54 degrees, which is pretty darn close to what we just determined, so we also agree with it. Alright, so now let's talk about our left axis deviation. So this is going to be if we have an axis of negative 30 to negative 90 degrees. So remember that 0 to negative 30, while it is shifted leftward and considered a non-pathologic left axis deviation, we do consider this to be within the bounds of normal. Now with our left axis deviation, we have pathologies that are either pulling the electrical axis to the left or other pathologies that are pushing the signal away from the right. So keep that in mind when we're looking at these potential causes of a left axis deviation. So we've got left bundle branch block, left anterior fascicular block can do this, left ventricular hypertrophy, so the enlarged ventricle is pulling at this point. If we have an inferior MI, we're losing that electrical signal over on the right and it's going to be pushing or shifting it to the left. Ventricular ectopy, especially those originating in the left ventricle. Paced rhythms can look this way. Wolff-Parkinson's-White syndrome can do this, as well as any mechanical shift of the heart from a raised diaphragm. So here think of things like our pregnancy, ascites, abdominal tumors, or even an enlarged liver or spleen. They're going to push up on that diaphragm and potentially shift and twist the heart. So let's look at a couple examples of a left axis deviation. So here is our first example here. Step 1, we want to isolate the isoelectric lead. So looking here, we can see that AVR is our isoelectric lead. So then we move on to step 2. This is going to be determining our perpendicular lead. So we can either reference that hexaxial chart or using that picture from our memory, we know that lead 3 is going to be our perpendicular lead to AVR. And then on to step 3, when we look at lead 3, we see that it is negative. So when we go to our hexaxial reference chart, we can see that this puts us in the superior left at the negative 60 degree mark. Therefore, we know the axis is around negative 60 degrees and it is in the pathological left axis deviation territory. For our next example here, let's go ahead and go through our steps. So step 1, here in this EKG, we can see that lead 2 is our isoelectric lead here. Moving on to step 2, from here, we're either going to be referencing, again, that hexaxial chart or from our memory. We know the perpendicular lead to lead 2 is directly across here with AVL. And then for step 3, if we look at AVL, we see that this is positive. So we then go to our hexaxial chart. Positive AVL puts us at negative 30 degrees, which falls into the pathologic left axis deviation category, although just barely in this example. So now moving on to our right axis deviation. So this is now in the inferior right side of our quadrant, and this is going to be from 90 to 180 degrees. So we have pathologies that are either pulling the electrical activity to the right or shifting them from left to right. So examples here of some causes include things like the left posterior fascicular block. If we've got a lateral wall MI on the left, we're not going to have the electrical signal there causing it to be pushed or shift over to the right. A large right ventricular hypertrophy is going to be pulling the signal over that way. Same with a PE, especially with the enlarged right ventricle. COPD and emphysema, they can cause pressure that can cause the heart to sort of twist and shift. Ventricular ectopy, again, this time originating in that right ventricle. Hyperkalemia, as well as sodium channel blocker toxicity can cause this. Again, Wolff-Parkinson-White syndrome. As well as this is also normal in people who have a horizontally positioned heart. All right, now for some examples of right axis deviation, here's the first example here. So we're going to go through this pretty quickly here. Step 1, we can see our isoelectric lead is going to be lead 2 in this example. So step 2, either referencing our chart or from our memory, we know that the perpendicular lead to lead 2 is directly across an AVL. And then for step 3, we see AVL is negative now, so going to our hexaxial reference chart, we know that we're in the inferior right quadrant with an axis of 150 degrees, making this a right axis deviation. All right, and this next example here, step 1, this one's a little harder to tell, but AVR appears to be the smallest and the most isoelectric lead. Step 2, we can then determine our perpendicular lead, again, hexaxial chart or from memory, giving us lead 3 as our perpendicular lead here. For step 3, we see that lead 3 is positive, so we again go to our hexaxial reference chart. We see again inferior right quadrant with an axis of 120 degrees this time, still giving us right axis deviation. And then now finally for our extreme axis deviation, this is something that's also referred to as a northwest axis, and this is certainly not a common one. So our extreme axis deviation is going to be now in that superior right quadrant and goes from our negative 90 to negative 180 degrees. Some potential causes of this can include things like having our electrodes misplaced, particularly our right arm and left arm electrodes being reversed or flipped. Ventricular rhythms such as VTAC, idioventricular rhythm, ventricular escape rhythms. If these are originating in the apex of the left ventricle, that signal is now moving in the opposite direction from what we would normally expect, and that can cause extreme axis deviation. Extreme hyperkalemia can cause this. Severe COPD or emphysema can also cause this, as well as ventricular pacing. Specifically, we've got the stimulation that's either in the apex of the right ventricle or left ventricle. All right, and then an example of extreme axis deviation, we've got one for you here. Step 1, again, this one's kind of hard to tell, but lead 3 appears to be the smallest and most isoelectric here. So for step 2, we determine that AVR is our perpendicular lead here. And then for step 3, AVR is positive, so if we go to the hexaxial reference, we can see that we are now in the superior right quadrant with an axis of negative 150, putting us into the extreme axis deviation territory. All right, and so that is the gist, the basics of cardiac axis determination. So like I said, it's really not that difficult of a thing to do, especially once you have that hexaxial reference chart to use in this. And really just going through 3 easy steps, looking at your 6 limb leads on your EKG, you can pretty quickly come up with a very close approximation of the degree of the cardiac axis, as well as knowing where that falls in our pathologies, whether that's normal, left or right deviated, or an extreme deviation. So I really hope this lesson serves as a foundation for you guys and gives you a little better understanding of what the heck we're even talking about when we're discussing the cardiac axis. All right, as we're nearing the end of this series on the 12-lead EKGs, and before we really get into the big topic of ischemia and infarction, one last thing that I want to review over are the changes in morphology that we see with enlarged chambers, both the atria and the ventricles. In this short lesson, we'll talk about atrial enlargement and the classic characteristics that will be present in our EKG, so let's go ahead and discuss that now. All right, so without much delay, let's dive right into our discussion here on atrial enlargement. And before we really discuss atrial enlargement, let's quickly discuss our P-wave morphology. So as we know, this is the first wave that we have in our entire complex. This is going to be the typically small hump that comes before the QRS complex and the T wave. Now, the morphology of this P wave, though, is really going to be dependent on what area of the heart is actually the pacemaker. Now, typically in most people, this is coming from the SA node, and we generally have a pretty consistent P wave. That said, if we look at these examples here, if we have 3 different locations that our beat is actually originating from, we would actually have 3 different looking P waves that we see here. Each one has its own different morphology when we're looking at it from the same camera, aka our lead, and depending on the location that it originates, it changes the appearance that we see picked up with that lead. So recognizing the different appearance of P waves in the same lead can really help us to identify beats that originate in different areas of the heart, such as with our premature atrial contractions or our PACs, our wandering atrial pacemakers, as well as our multifocal atrial tachycardia. With the wandering atrial pacemaker and the multifocal atrial tachycardia, we're generally going to see multiple different morphologies as a result of many different irritated areas of the atria that are responsible for initializing depolarization and contraction. So I did just want to show you a couple examples of both of these. As you can see here on top, we have a normal rate, but we have multiple morphologies of P waves. This first one here looks different from the second one as well as from the third one. And so this is actually an example of our wandering atrial pacemaker. In the bottom example, we have the same thing with multiple morphologies of P waves, yet here we now have a rate that's actually tachycardic, and thus this would make it multifocal atrial tachycardia. All right, so now let's move on and talk about our actual atrial enlargement. And the first one we're going to discuss is going to be our left atrial enlargement, or LAE. So with this, we have a P wave that has an appearance that we call P mitral. Here we have a notched P wave that really kind of reminds me of camel humps. The notched P wave is the result of prolonged conduction time through the left atrium due to its enlarged size. So the conduction begins rather quickly through the smaller right atrium that, if I draw that out here in blue, then it begins later and then conducts through the left atria, that would be the section here in red, thus giving it the two peaks here. So when they combine together, that's what gives us this appearance. Now, one other criterion for left atrial enlargement is that the P wave is greater than 0.12 seconds, so 3 small boxes, when we're particularly looking at it in the limb leads, and this is best in leads 1 and 2. And then just quickly on some causes of left atrial enlargement, really the most common cause here is going to be severe mitral valve disease, although aortic stenosis can also lead to this. The reason for this is, so with mitral stenosis, that this requires the left atrium to contract stronger against that resistance that it gets in the valve, leading to increased muscle mass and thus size. With mitral regurgitation, that this actually leads to increased volume regurgitating back into the left atrium. This leads to dilation and thus the larger size that way. And this can help in remembering this as left atrial enlargement as the P wave appears like an M, so think mitral on the left side. And so here's a quick example of a rhythm strip with P mitral present in lead 2. As you can see, we have that classic notched P wave, and it is longer than 0.12 seconds or 3 small boxes. All right, so now let's move on and talk about our right atrial enlargement. And this is something we also call P pulmonale, and it's really characterized by a large peaked P wave, and this is going to be classic in right atrial enlargement. So the P waves will be most prominent in the limb leads, especially leads 2 and 3, and here the enlarged right atrium, where conduction begins, is added to the rapidly depolarizing left atrium, giving us the appearance of this large P wave. The other criterion here is that the P wave height has to be greater than 2.5 millimeters, so basically 2.5 small boxes. And then some common causes for right atrial enlargement are pulmonary hypertension, pulmonic stenosis, or tricuspid valve disease. This includes both tricuspid stenosis and tricuspid regurgitation. And again, here is another example of a rhythm strip, this time with right atrial enlargement. And here are the classic peaked P waves, which are larger than 2.5 millimeters, again, 2.5 small boxes. All right, so just to expand upon this a little bit more, I want to talk about intraatrial conduction delay and biphasic waves. So another way to distinguish atrial enlargement is with biphasic P waves in lead V1. So these biphasic waves are indicative of a nonspecific conduction problem in the atria. Now, usually this is caused by atrial enlargement, but the enlargement really may not be enough to cause that classic P mitral or P pulmonale patterns. Essentially, if we see a biphasic P wave in V1, then we need to determine if the first part or the second part is the larger or dominant part. So in left atrial enlargement, we would see the second part of the P wave as the larger part. And this part of the wave would also be at least 0.04 seconds or 1 small box wide. In this example here, when looking at the P wave in V1, we see that it is biphasic, with the largest part being the terminal second part, which is greater than 0.04 seconds, thus telling us that we have left atrial enlargement. Now on the flip side, with right atrial enlargement, we would actually see the first part of the P wave as the largest part, but along with that first part, this P wave has to be taller than the P wave that we see in V6. So in this example here, we see again we've got a biphasic P wave in V1. This time the first part of that biphasic wave is the largest part, as well as when we compare it to the P wave that we see over in V6, The first part of the P wave here in V1 is clearly larger, thus giving us right atrial enlargement. And one little thing to try to help you remember this is, again, remember that that beat is originating in typically the right atrium in that SA node. And therefore, if the first part that we see enlargement, so the larger part of the biphasic wave, we know it came from the right atrium first, so this is going to be right atrial enlargement. And then the second part of the biphasic wave, we know the left atrium is then being depolarized following that. Therefore, we would know that if that's the largest part, we have our left atrial enlargement. All right, so knowing this, that this really carries us into the discussion on biatrial enlargement. So as the name suggests, biatrial enlargement is when we have enlargement in both the left and the right atria. The way that we identify this is by identifying signs of both left atrial enlargement and right atrial enlargement together. So if we see peaked P waves, so P pulmonale, as a sign of right atrial enlargement, and we have biphasic P waves in V1 with a dominant second part of the wave, a sign of left atrial enlargement, then we would meet criteria for biatrial enlargement. Now, on the other hand, if we see signs of a notched P wave, so this time P mitral, a sign of left atrial enlargement, along with a biphasic P wave in V1 with a dominant first part of the wave, which also happens to be larger than the P wave we see in V6, that this is a sign of right atrial enlargement, then again, we've met criteria for biatrial enlargement. And then finally, the more difficult one to identify is when we don't have it severe enough to either give us the P mitral or P pulmonale P waves, but we do have a biphasic P wave in V1 that is both larger in the first part than the P wave in V6, so a sign of right atrial enlargement, as well as having a large second part of the biphasic wave that's greater than one small box, so 0.04 seconds, that this is a sign of left atrial enlargement, and together this leads us to identify biatrial enlargement. And so that was the quick overview of our atrial enlargement. So this is one part which when we combine together with the next lesson, which is going to be on our ventricular enlargement, something we refer to as hypertrophy, when we combine these two together, when we sort of think about our anatomy, which I'll talk about more in that lesson, that we can start to evaluate and kind of understand some valvular disorders that may be going on with our patient, all just from the EKG that we see. In the last lesson, I mentioned that I wanted to cover the enlargement of chambers as we see them really manifest on the 12-lead EKG before finally moving on to talk about ischemia and infarction. We started off with atrial enlargement, so now let's move on to the enlargement of the ventricles, aka ventricular hypertrophy. All right, so to get in and start things off, we're going to begin talking about our QRS complex wave composition. So we previously discussed the composition of this QRS complex, with it usually consisting of our Q, R, and S wave. That said, we don't normally see all waves in all complexes in all leads. The waves that we see, though, are combinations of the combined average direction of electrical activity in the heart at that moment in time, and really relative to the electrode that's particularly looking at the heart. So remember, if we take a look at our heart here, remember that the septum is typically going to depolarize first. This is then going to be followed by the ventricles, really overpowered by that main left ventricle going in that inferior and lateral direction. And then on to the rest of the ventricle, which is depolarized from the inferior to superior direction. So remember, though, that these are not just discrete events, though. In fact, they actually flow together over time. So if we actually look at this from the frontal plane looking at the heart, let's say if we're looking at lead 2, we can see with our complex here that we have each of the directions of electrical activity that over time are contributing differently to the waveform that we see. And then we can see as the colors kind of blend together, this is signifying that we don't just have those discrete events of electrical activity, but they're all kind of happening, together over time and then sort of flowing together. So the same concept we can also apply to our precordial leads when we're looking at the heart in that horizontal plane. So here, if we take a look at our 6 precordial leads from V1 to V6 in relation to our heart on the horizontal plane. So we have the same depolarization from the septum to the main left ventricle in that lateral inferior direction, and then on to the rest of the ventricle in a superior direction. This then gives us the following complexes as we see them for each of the 6 precordial leads. And we can see how here that the different moments in time, the different depolarization events have the effect on the different waveforms that we see in each of these leads. And you can see how when we transition from V1 to V6 and we move from a more rightward view of the heart to a more leftward view of the heart, that the waveform here is changing. So now we can have various pathologies that can really affect these complexes and their amplitudes. So for an example, previously we mentioned in a past lesson that we can see reduced size of these complexes in patients that have pathologies that inhibit conduction, such as COPD, obesity, and pericardial and pleural effusions. On the other hand, we also have various pathologies that can alter the flow of this electrical activity, so think our bundle branch blocks, as well as things that can actually increase the size or the amplitude of these complexes. So if a patient has had an MI and we've had an area of dead tissue, that this is actually not going to block or slow down any electrical activity through there. This can actually allow the signal to move through the tissue more easily, leading to a larger waveform. Also, if there's an enlargement of the tissue, either through stretching or through thickening, that this can also lead to more electrical activity, giving us larger waveforms. And in this lesson, that's specifically what we're going to be looking at is the enlargement of a ventricle or ventricles. Again, something that we refer to as ventricular hypertrophy. All right, so on this topic, let's go ahead and move on and start talking about left ventricular hypertrophy. And so as the name suggests, this is going to be enlargement of the wall of the left ventricle. Now, in general, ventricular enlargement is really going to be the result of 2 primary issues. So we either have some sort of outflow problem. So here the heart muscle must contract against a strong pressure that's either coming from high blood vessel pressure, so think hypertension, or a stenosed valve going from the ventricle to the blood vessel. So another example would be like aortic stenosis. Or we can see the enlargement as a result of some sort of dilation or volume issue. So this is a volume overload. And this could be like a valve that's leaking blood back into the heart after it's emptied, but some sort of volume issue that's going to lead to dilation and enlargement of that ventricle. So we actually have many different proposed ways to determine if we actually see or have evidence of left ventricular hypertrophy present on our EKG. All of them involve looking at either R waves or S waves. So let's actually make sure we're on the same page with these. So the R wave, that this is going to be the first positive deflection that we see in a complex, while the S wave is the negative deflection after the positive deflection, or if the only deflection that we have is negative, then this is also our S wave. So the 2 most common criteria for looking at and identifying left ventricular hypertrophy that we're going to use here look at either the precordial leads or the limb leads. I'll go over some examples in a second here, but let's talk about the criteria that we use. And one important thing to keep in mind is for each of our EKGs that we're evaluating, we really want to evaluate both of these because sometimes we can see criteria being met with one of these and not with the other and vice versa. So they both are pretty quick to roll through. And when we do our examples here, we'll actually look at both of these as well. All right, so the first is going to be the Sokolow-Lyon criteria. And this is the most commonly used one, and this is actually looking at our precordial leads. So here we're going to add the voltage or the height of the S wave in V1 to the voltage of the R wave in either the larger of V5 or V6. After we add them together, we're going to see if our total is either greater than 35 millimeters if the patient is greater than 40 years old, greater than 40 millimeters if they're 30 to 40, or greater than 60 millimeters if they're under 30, or at least in terms of adults. Now the next criteria is something that we call the Sokolow-Lyon standalone criteria. And this is a simpler look at the limb leads for this criteria. And here we're actually looking for the height of the R wave in our limb lead AVL, and to meet this criteria, it needs to be greater than 12 millimeters. Now, having met criteria for either of these, we would consider the patient to have met criteria for left ventricular hypertrophy, and certainly stronger evidence if both are present. So one thing to note, though, with the left ventricular hypertrophy that I will be discussing in the next lesson more is that similarly to what we can see with our left bundle branch block, we can also see ST segment elevation, something we call left ventricular hypertrophy with a strain pattern, but it's not indicative of a STEMI. So this presentation can often look like an acute anterior STEMI, but again, we will discuss that more in the next lesson. All right, so let's take a look at a couple examples of left ventricular hypertrophy, and let's see how we can see the criteria in them. So here's going to be our first example here. And so to start off, we need to take a look at our precordial leads, V1, and then either V5 or V6. Looking at the voltage or the height of the S wave in V1, if we count up from our isoelectric line down to the bottom of our S wave, we can see that we have 15 millimeters. And so now if we look at lead V5 and V6, it is pretty close, but I do think our biggest wave can actually be found in V5. And if we look at the voltage of the R wave here, it looks like, again, from the isoelectric line to the top of our R wave, looks like we have about 16 millimeters. So if we add V1 and V5 together, we get 15 plus 16, which gives us 31 millimeters. So regardless of the age of the patient, even if they're greater than 40 years old, we would actually be just shy of meeting criteria for left ventricular hypertrophy looking at our precordial leads. But like I said, we don't want to do just the one criteria. So next, we actually want to take a look at our standalone criteria for the limb leads. And again, here we want to look at AVL. So if we look for the largest R wave that we have here, for example, this one here, we would find that we have a voltage that's just over 12 millimeters. So this would barely meet criteria for us to call this left ventricular hypertrophy in this particular patient. All right, so hopefully you can kind of see how we roll through those different criteria and make that determination. Let's take a look at one more example specifically for left ventricular hypertrophy. Again, let's start off with our precordial leads V1 and either V5 or V6. So in V1, here is an example of a good waveform here. The voltage of our S wave in V1 here, this one's pretty deep, as you can see, going from the isoelectric line down to the end here. We're looking at about 28 millimeters. So then next we need to take a look at the voltage of the R wave in either V5 or V6. In our example, again, the height of the R wave in V5 I think is the larger one. So here is a good example of that, and it appears that we've got a height of about 37 millimeters. And so when we add up V1 and V5 together, we get 28 plus 37, which is 65, which is well above any of the criteria that we've got listed up here for any of the age groups that we discussed earlier. So, based on this information, we would have evidence that we need to call this left ventricular hypertrophy. We don't want to stop there though, so let's also take a look at our limb lead and AVL for our standalone criteria. So here we'll take a look and we'll enlarge this waveform here, and we're looking at the amplitude of the R wave again, which you have a height of about 15 millimeters. So this is greater than the 12 millimeters per our criteria, so we can also use this as further evidence of left ventricular hypertrophy in this patient. Now in this second example, I do want to quickly point out the presence of ST elevation in leads V1 and V2, some of our anterior septal leads, as well as ST depression in leads 1, AVL, V5, and V6, which would be our reciprocal lateral leads. Now, in the absence of left ventricular hypertrophy, this could appear as an acute anterior septal STEMI with those reciprocal changes in the lateral leads. But as I mentioned earlier, this is actually an example of left ventricular hypertrophy with strain pattern. Again, something I'm going to discuss a little bit more in the next lesson. All right, so in addition to seeing patterns that suggest left ventricular enlargement on EKG, we can also see criteria that would be consistent for patients with enlargement of the right ventricle, or what we call right ventricular hypertrophy. So with right ventricle hypertrophy, since the right ventricle is enlarged and larger, we're actually going to see greater electrical activity coming from that side of the heart. So one of the first indicators and the first criteria that we're going to look for is we're actually looking to see if there is a shift in the electrical axis of the heart into the right axis deviation. But then for the next criteria, once we have that, we need to take a look at V1. So we want to start off comparing our R to S ratio and checking if it's greater than 1. What does this mean? So essentially we're comparing the amplitude of the R wave to that of the S wave in V1. So remember that we have our R wave followed by our S wave, and if we put up two examples here, in this first example, our R wave is going to be smaller than our S wave, giving us a ratio of less than 1. In the second example here, we actually have an R wave that's bigger than our S wave, which would give us a ratio greater than 1. And if you remember, typically in our EKG, looking at our precordial lead starting in V1, we're expecting to see very negative waveforms that begin to become more and more positive as we move further down the precordial leads until we get to V5 and V6, where we generally have the largest positive waveforms. And so what we're looking for here on V1 is if that has flipped, and if we're seeing a larger R wave than an S wave in V1, this is looking at more of the rightward view of the heart. And so this would be an indication that we've got more electrical activity coming from the right side of the heart. So depending on the EKG, this may be something that you're able to tell on here just by eyeballing this, but more precisely, you can just measure out the voltage of each of the waveforms in small boxes and then figure out the ratio that way by dividing. Again, we'll cover this here in just a minute with an example. Now, we also want to observe if we have a QR complex that's present. So as you can see with this example complex here, with a QR complex, so if we have a Q wave that's followed by an R wave that's greater than 7 millimeters, that this is also another criterion, specifically, again, if we're looking at V1. Now, both of these are not going to be present, but we're looking for either one of these being present, and if either one is present in V1, that this is an indication of stronger forces on the right side of the heart. Again, remember that R wave progression, like I talked about, precordial lead starts very negative in V1 and transitions to positive as we move to V6. So on that last note, the last criteria that we want to look for is actually if we look at our leads V5 and V6. Here we're looking for the opposite pattern of what we just looked for in V1. Because like I just talked about, we're normally going to expect to see those larger positive complexes, which would give us an RS ratio greater than 1 normally. And so with that said, if we compare the RS ratio in these leads and the ratio is now less than 1, that this would also be an indication of stronger electrical activity on the right side of the heart. So it was a little bit more complicated of a criteria than with the left ventricular hypertrophy. So let's actually look at an example of right ventricular hypertrophy on an EKG and kind of talk through this, and hopefully that will make a little bit more sense. All right, so here is our example EKG here. And when evaluating the EKG for right ventricular hypertrophy, remember first we want to look at our cardiac access. So this example that I have here isn't set up like how we normally expect to see them, nor does it show us the computer's interpreted numbers and all that stuff. But I will go through this real quick, but make sure you refer back to that lesson on cardiac access if you do need a refresher on this part. So we want to look for our most isoelectric line, which is going to be present here in AVR. Thus, we know that our perpendicular lead to AVR is going to be lead 3. Here we have an upright wave in lead 3, which then if we look at our hexaxial reference chart, we see that a positive lead 3 gives us an axis of 120 degrees, putting us in the bottom right quadrant and indicating right axis deviation. So this is our first criteria met, and this is an indication that we have greater electrical activity coming from the right side of the heart. Now, having right axis deviation, we need to take a look at V1 and see if we have a RS ratio that's out of whack or those QR complexes. So in our example here, we don't have QR complexes, so we're going to look at our RS complexes in V1 and look at that RS ratio. Here it's pretty obvious just from looking at it that the R is much larger than the S, giving us a ratio greater than 1, being another indication of right ventricular hypertrophy. Now, if we did need to measure this out, we'd see that from the isoelectric line to the top of our R wave, we have about 17 millimeters. And then from the isoelectric line to the bottom of our S wave, it's about 5 millimeters. Thus, we would take 17 divided by 5, which is greater than 1. So finally, we want to take a look at either V5 or V6. Again, here we're looking for the inverse of what we were just looking at in V1. So we're still going to be looking at that RS ratio, but this time we're now looking for it to be less than 1. So looking at V5 and V6, they are pretty close in size. So for this example, let's just look at V6 here. Looking at the R wave and the S wave, they're actually pretty close in size. So the R wave looks like it measures out to about 10 millimeters, and the S wave looks like it measures out to about 10 millimeters as well. Therefore, we're right at a ratio of 1, which, while it technically doesn't meet the criteria in this lead to call this right ventricular hypertrophy, it is pretty close. And given that we do have findings of right axis deviation and that RS ratio being greater than 1 in V1, as well as just the fact that we typically would expect to see a pretty positive RS ratio in V5 or V6 at this point. So the fact that this is right at 1, I feel like we can pretty safely say that this patient probably meets the criteria for right ventricular hypertrophy. All right, so we covered a lot of information going over our ventricular hypertrophy, looking at both the left and the right ventricles, and really how we're going to be able to see that on our 12-lead EKG and identify that. So now that we've covered a lot of stuff looking at our 12-lead EKGs, we're finally going to move in and start to talk about our ischemia and infarction, our STEMIs, non-STEMIs, all that stuff over the next couple lessons. And then finally, we should be finishing up with the 12-lead EKG series. All right, up to this point, we have covered many various aspects of our 12-lead EKG. The final aspect that we need to take a look at, and really arguably the most important part, is evaluating for ischemia and infarction. This will be divided up into the last few lessons that we have here in this series, starting with this lesson where we're going to take a quick look at our ST segment and our T wave. So both the ST segment and T wave are going to be important in our evaluation of possible ischemia and infarction on our 12-lead EKG. Of all the different parts of the EKG, these two areas may be the most important for you to have a good understanding of. For example, if we have ST depression with flipped T waves from normal, then this is going to be a sign of ischemia. If we note ST elevation with or without flipped T waves, then this is going to be a sign of infarction. Therefore, it really helps to make sure that you have a good foundation of understanding of these before we move further into the discussion of ischemia and infarction. So let's start off talking about our ST segment. So our ST segment really is a representation of time from when the ventricles finish depolarizing and before they start repolarizing. So if we take a look at our waveforms on EKG, we measure our ST segment starting from the end of our QRS complex. So this is at something that we call the J point. The ST segment then goes on and ends at the start of our T wave here. Now, it is common for either the J point or the start of the T wave to not necessarily be perfectly defined, and therefore we often have to make an approximation of these points. So, real quickly, here are two examples of different J points. The first is going to be something that we call a sharp J point, meaning that it's really easily identifiable. So here the transition from our QRS complex to our ST segment is going to be well defined, and as such, we can easily identify the J point right here. Now, the second one, though, we refer to as a diffuse J point. With this one, it's less clear exactly where the QRS ends and the ST segment begins. As you can see with this one, the transition from the QRS complex to the ST segment is really a slow and sloping, making it hard to really determine the exact spot at which the J point takes place. Instead, we can really kind of identify the area in which this transition occurs, which we could say would be roughly around here, but really we can't identify the exact location. Any identification more than just this area would simply be us guessing. Now, we're often going to see diffuse J-points with things like left ventricle hypertrophy with strain pattern, pericarditis, as well as early repolarization, but we can also see diffuse J-points in MIs, especially when we have tombstoning present. So now, once we have our ST segment identified, what we really want to do is compare its height to that of the isoelectric baseline. Depending on where it is in relation to the baseline, that this is going to determine if we have ST elevation or ST depression. Now, the isoelectric baseline is going to be best measured from the TP segment, so the end of the T wave to the start of the P wave of the next beat. Now, this may actually be difficult to see, though, especially in patients with fast heart rates. Therefore, you may need to use the PR interval or really just your best judgment if the T and P waves are really too close to have a good TP segment. But in terms of identifying whether we have ST elevation or depression present, here are some examples of 3 different waveforms. The first one being just a normal waveform. We don't have any ST depression or elevation here. It's right at the isoelectric line. The next one being ST elevation, which we can identify because the ST segment is above the isoelectric line. And then finally, the third one being ST depression. Again, here we see our ST segment. This time it is below the isoelectric line. And so when we're trying to identify if we have ST elevation or depression present, we really want to count up the boxes between the isoelectric line and where the ST segment is. Now, it is normal to have less than 1 millimeter of ST elevation in any of our limb leads, while in V2 and V3, we can actually have up to 2 millimeters of elevation for men older than 40 being normal. Here it goes up to 2.5 millimeters if they're under 40. And then for women, up to 1.5 millimeters of elevation is considered normal as well in these leads. For the remaining precordial leads here, we're also going to expect to see less than 1 millimeter of ST elevation. Remember, though, that with all of this, that we want to correlate this with the patient and how they're presenting, the morphologies that we see on EKG, their history, as well as if there's any reciprocal changes present. And it's important to remember that if any elevation is present that wasn't there on previous EKGs, or if the patient is presenting in a way that matches ischemia, that any elevation really can be considered pathological. The last thing I want to review over for our ST segment in this lesson is going to be the shape of our ST segment. So there's many different shapes of the ST segments in various conditions, both with elevation and depression, which may or may not indicate ischemia or infarction. So we can have flat, upsloping, and downsloping ST segments, as well as something we call concave or convex ST segments. And we can see these with both ST elevation and depression, and certain shapes are going to be more common than others, and some shapes can signify specific conditions that are present. So I am going to be covering these, including various potential causes of some of these in the next couple lessons, but I did want to make mention of them here. All right, now that we've talked about the ST segment, we also need to discuss the T wave a little bit more. Now, we've already previously discussed this some in previous lessons, but I did just want to hit on a few points that are going to be important as we move into talking about ischemia and infarction. So there are various morphologies, but we can really group them down into 3 basic things: our shape or symmetry, the size, as well as the polarity of the T wave. So to start off, let's talk about the shape or symmetry of the T wave. So when talking about the shape of the T wave, first we really want to evaluate something we call the symmetry of the T wave. Normally the T wave is going to be asymmetrical, meaning if we divide the T wave at the peak, that the 2 sides are not going to be equal. So here are 2 examples of T waves. The first one is a normal asymmetrical shape. As you can see, if I divide the wave from the peak here, the first part is actually much larger than the second part. In the second example, this is actually a symmetrical T wave. Dividing it down from the peak, we can now see that we have both halves that are basically the same size. Now, symmetrical T waves are pathological. We often will see them with ischemia, electrolyte abnormalities, as well as some CNS problems. early identification of MI can occur also with the presence of symmetrical T waves. That said, some people do actually have normal symmetrical T waves, but if we do see them, we need to rule out them being pathological before considering it normal. Now, sometimes determining the symmetry of the T wave is going to be difficult due to our ST segment. So if there's elevation or depression that's present, you really just need to continue the line of the T wave to the isoelectric baseline, and this is often going to help to identify these. So along with the shape and symmetry, we also want to look at the size of the T waves, and here we can see things like short and tall, as well as narrow and broad T waves. So tall, narrow T waves are going to be common with things like hyperkalemia, while broad T waves can actually be present with various CNS problems. So here are a few examples of various T wave shapes just to give you an idea of some of these. First, we've got a couple asymmetrical waves, both positive and negative. Then we have some tall peak T waves as well as tall and broad. And then finally we have some very broad, remember think CNS here, both positive and negative T waves. Then when we're looking at the height or depth of a T wave, generally we don't expect to see the T wave more than 2/3 the height or depth of the QRS complex. This we would definitely consider abnormal. And then finally with the morphology of the P wave, the last thing we want to talk about is the polarity. So repolarization of the ventricle creates its own flow of electrical activity. We can see positive, negative, as well as biphasic T waves. Normally though, we expect to see positive T waves in leads 1, 2, as well as V3 through V6. And then AVR, we expect to see negative T waves. And the rest of the leads really can be variable. Now if the T wave is in the opposite direction that we expect, this is something that we call flipped. Flipped T waves can be a sign of myocardial ischemia, although we can see them with some pathologies such as hypertrophy as well as bundle branch blocks. And then we also can see something that we call biphasic T waves in any of our leads. That said, if we have biphasic T waves with the first part of the biphasic wave being positive, that this is often going to be normal, where if we have a biphasic T wave with the first part negative, that this is more likely to be pathological. Alright, so that covers our quick review of our ST segment and our T waves. Again, we're going to talk about more of this in the next couple lessons as we begin our discussion about ischemia and infarction. In fact, in the next lesson, we're going to take a quick dive into various different patterns that we see that may indicate or look like an ischemia or infarction on first glance, but actually are related to other pathologies. And then finally into the following and last lesson in this series, we're going to be taking a look at our actual ischemia and infarction, and then the ways that we identify this on the 12-lead EKG. Alright, we've covered a lot of information over the last series of lessons looking at our 12-lead EKG. All this information is very important in being able to help you to evaluate your patient's 12-lead EKG and to help find any changes that could be signs of various pathologies. One of the most important of these for us to recognize is when our patient is experiencing a lack of oxygen, also known as ischemia and or infarction. We'll take a good look at just that over the next couple of lessons, starting with our introduction to acute myocardial infarction in this lesson here. So as I mentioned, this lesson and the next couple following lessons are more than likely the most important aspects of our 12-lead interpretation. While many of the other findings can certainly be important in diagnosis and treatment of our patients, the identification of ischemia and infarction and the subsequent treatment of such has the potential to save the patient's life. With that in mind, you can understand the importance of being able to recognize these both on our 12-lead and combined with our presenting signs and symptoms. I will do a future lesson more directed at this presentation and our patients as well as our management, but the purpose of this lesson will be on what we are looking for on our 12-lead specifically. The subject around ischemia and infarction really has the potential to be a very complicated and in-depth discussion. Over the next few lessons, this will serve as a good introduction to these subjects, but there's certainly much more information that you can learn if you really choose to by diving deeper into various topics. So let's start off with the basics. And really before we begin, let's make sure that we're on the same page with our discussion of this topic. So this lesson will cover these things and our basic overviews. And the next couple of lessons will look at our actual EKGs and various pathologies that we would see. So when we're discussing ischemia and infarction, what we're referring to is situations in which the heart is not getting the oxygen that it needs to function and survive. All the cells require oxygen to survive, and our myocardial cells are no different. In fact, they have some of the highest demands for oxygen of any cells in our body. When cells begin to exist in a state where there's not enough oxygen to meet the metabolic needs of the cell, the way the cell operates begins to change. Initially, they're going to switch from aerobic to anaerobic metabolism, which is where that energy production takes place in the absence of oxygen. And remember that this is nowhere near as efficient as aerobic metabolism, and it also produces lactic acid as a result, creating an acidic environment with ineffectual energy production. Now, if this oxygen-deprived situation persists, then the cells will build up these harmful metabolites combined with inadequate energy production and will eventually lead to injury of the cell. If this process continues without reversing the situation that's causing the lack of oxygen, then eventually the cells will die. So we can think of this process from lack of oxygen as something that really takes place along a continuum from a normal state of functioning to ischemia, which is a state of inadequate oxygen delivery for normal functioning, then to injury of the cell, and eventually to infarction, which is cell death. As our patient progresses through these stages, we'll have some generally well-defined presentations, both from signs and symptoms standpoint, as well as EKG changes that we'd expect to see, which we will be discussing here soon. When we look at ischemia and injury, both of these typically will manifest with chest pain, but they are reversible. They are the result from an imbalance between the oxygen being delivered to the heart and the metabolic demands of the heart. So this can result in either or both from an increase in the demand of the heart and the oxygen that it needs, or a decrease in the supply of blood and oxygen that's going to the heart. Infarction, since it's the death of a cell, is not reversible and will certainly have permanent impact on our patient, the degree to which will really depend on the extent and severity of this cell death. Alright, so now let's take a look at the distribution of blood flow through the myocardium. Understanding this distribution of blood flow is really going to help to understand the shapes of infarctions and how they're going to manifest on EKG. Now, from the main arteries, which are on the epicardium or the surface of the heart, the blood vessels begin to branch and dive into the myocardium. This branching, we can think of a tree-like structure where as they go deeper and get closer to the endocardium, they divide and branch into smaller and smaller vessels, spreading out in an upside-down tree-like presentation. So because of this branching pattern, each big branch ends up perfusing a wedge-shaped section of the myocardium that is going to get wider as we approach the endocardium. Now, these wedge-shaped sections end up overlapping like we can see here, which allows for some cross-coverage of some of these areas. Now, when we have infarction or cell death that takes place, we'll see the cells die in a similar wedge-shaped pattern that gets wider as we approach the endocardium, in relation to the branch that is perfusing that area of the heart. Now, spreading out from the area of infarct, we also have areas of injury and then ischemia. But these areas spread out with wider areas closer to the epicardium. And this is the result of a few different things. So as I mentioned, we have those overlapping wedge-shaped sections of perfusion, really allowing the other branches to help perfuse some of the distal areas closer to the endocardium that other branches are also perfusing. We can also see oxygen that diffuses directly from the ventricles into myocardial tissue that's closer to the endocardium. And then finally, we have some small blood vessels called the Thebsian veins that may also exist coming straight off the ventricles, which can also help supply blood to these areas. So these factors combine to help provide extra oxygen to the area of the myocardium that's closer to the endocardium, helping to make them less likely to be impacted by ischemia and injury. Alright, so now let's talk about the zones of presentation of ischemia, injury, and infarction. What we're going to be doing is taking a quick look at the impacted areas in 3 different scenarios. So first is going to be ischemia. So this lack of oxygen, as we just discussed, will impact an area of the myocardium that is in a wedge-shaped pattern. with a wider section along the epicardium, as you can see here. This area of ischemia ends up being more negative than the normal myocardial tissue, which leads to ST depression on EKG. Along with that, we also have repolarization that's going to be taking place along an abnormal pathway, giving us inverted T waves there as well. Next, progressing along, if we take a look at injury, we also see a similar wedge-shaped pattern wider near the epicardium, just like with ischemia. A big difference now is this area of injury is not going to repolarize properly or completely, keeping this tissue more positive than normal myocardial tissue. The result of this is ST elevation appearing on our EKG. Again, the repolarization is taking place abnormally, leading to the persistent T-wave inversion. And then finally, when we take a look at infarction, this is now myocardial tissue that has died. As a result of the cell death, this tissue is no longer generating any electrical activity. In fact, this area of infarcted tissue actually acts as a quote-unquote window in which electrical activity from the other side of the heart can actually pass through or be viewed through this window. So this can actually present on EKG as electrical activity being picked up that's going away from the electrode, thus negative, and thus produce the negative Q wave. Now this doesn't always happen. In fact, we can have infarction that doesn't impact the entire length of the myocardium, not giving us this window to see through, and thus not seeing Q waves, as well as can also be small enough as to not cause ST elevation, and in fact ST depression, sometimes giving the appearance of ischemia. Now this discussion is going to be beyond the scope of this lesson in the series, but certainly something for further research if it's something that you desire. So back to our normal infarction, we do see even more ST elevation due to the extent of injured tissue surrounding the infarcted tissue. And again, we continue to see inverted T waves due to the continued abnormal repolarization pathways. All right, so finally for this lesson, I wanted to review over the classes of acute coronary syndrome, or ACS. So these conditions cover the continuum of cardiac conditions from ischemia. So I'll probably do a future lesson at some point like I talked about earlier, where I'm going to cover this and its management in more in depth, but for now a basic overview is going to be important here. So we have three main classes of ACS. We have unstable angina, non-ST segment elevation myocardial infarction, or NSTEMI, and our ST segment elevation myocardial infarction, or STEMI. So let's start off talking about unstable angina. So this is a condition in which the patient is currently experiencing ischemia with chest pain. So this can either be at rest or minimal effort or activity. Patients are usually going to present with that chest pain, along with those associated symptoms like shortness of breath, palpitations, diaphoresis, nausea, and or vomiting. Our patient's EKG is either going to look normal or present with ST depression and or T-wave inversion. Our cardiac markers such as troponin are actually going to be negative, and we can really think of this as pre-infarction angina, where severe ischemia exists but has not led to cell damage or death. All right, so moving on to NSTEMI. So NSTEMI is again a severe ischemic state with those typical signs and symptoms that we just discussed with unstable angina. On EKG, we are going to see ST depression and T-wave inversion. The big difference between NSTEMI and unstable angina is that we have myocardial cell damage, and thus our cardiac markers are going to be elevated. And then finally for STEMI, this is another severe ischemic state with the same presentations that we already mentioned. With STEMI though, we're actually going to see ST segment elevation on EKG. And remember that these ST elevations are going to present in those regions on the EKG that correspond with the areas of injury, along with those reciprocal changes seen in opposite leads. I did discuss this very early on in this series, but as we move forward, we are going to re-hit this again in the future lessons. So a STEMI is typically going to be associated with a coronary occlusion. So this means the patient is going to need emergent intervention to reperfuse the tissue to prevent further damage. All right, so now that we've discussed all that and you have hopefully a good introduction to the subject of acute myocardial infarction, we can get to the last few lessons in which we're going to take a look at these and their presentation on EKG to hopefully round out your understanding of what to look for when you're reading 12-lead EKGs. Nearing the end of our 12-lead EKG series, we're going to be taking a good look at ischemia and infarction over the next couple lessons. In this lesson specifically here, we're talking about seeing ST depression and T-wave inversion on our EKG, and especially in relation to ischemia and the importance of such, along with its recognition. So being able to recognize and evaluate changes on the 12-lead EKG is really paramount in being able to pick up on various pathologies that may be going on with your patient, especially when we're considering possible ischemia. In this lesson here, we're going to be specifically looking at ST depression and T-wave inversion, and most notably in the context of STEMI. Alright, so let's start off with the basics here. When talking about ST depression and T-wave inversion, that these can both be caused by a multitude of different things. Obviously, the most concerning is ischemia, but it is important to be able to recognize these for other reasons as well. We can see both ST depression and T-wave inversion in the setting of being secondary to a depolarization abnormality. So here, think our bundle branch blocks, both our left and our right bundle branch, ventricular hypertrophy, both left and right, or in Wolff-Parkinson-White. In these cases, these findings are generally not concerning. That said, if we have ST depression and or T-wave inversion in the setting of normal depolarization, we consider these to be primary. Thus, if we have primary ST depression and T-wave inversion, and the patient is exhibiting signs and symptoms of ischemia, then we need to assume that these are manifestations as a result of the ischemia. That said, we can have both primary and secondary ST depression and T-wave inversion that can really complicate the picture. Typically here, we're going to see deeper ST depression and T-wave inversions, especially if we compare it to previous EKGs where only the secondary is present. And with these, we're usually going to be able to see these as disproportionate when we compare them to the size of the QRS complex. Alright, so now let's take a deeper look at ST depression. So when it comes to measuring ST depression, remember that we want to measure the ST segment in relation to the PR segment. We want to measure from the J point, and anything more than 0.5 millimeters, so a half a small box, and at least 2 anatomically contiguous leads, that we would consider this ST depression. Now, some of our causes of ST depression, we can have non-ischemic causes such as therapeutic digitalis usage, tachycardia, metabolic or electrolyte abnormalities, especially hypokalemia, as well as some people just have normal ST depression present, although this is usually going to be less than 1 millimeter. Now, we do also have those secondary conditions that we just talked about, such as the bundle branch blocks, ventricular hypertrophy, Wolff-Parkinson's-White, as well as post-cardioversion. We can also see this as well. But the most concerning is if we have ST depression that is the result of ischemia. Again, if a patient presents with signs and symptoms of ischemia, even in the presence of the above non-ischemic causes, we need to assume ischemia and rule that out. So we can see ST depression in the context of reciprocal changes from ST elevation and other leads. So here, the areas of the heart that are opposite of the ST elevation are actually going to appear as ST depression. This is just a real quick intro into this subject, and we're actually going to be discussing this much more in the next lesson. Now, in addition to reciprocal changes, if the patient is actually having a posterior transmural infarction or a posterior MI, we wouldn't actually see the ST elevation since our leads that we normally place don't actually have a view of the posterior. With this, we're only going to see those reciprocal ST depressions in our anterior leads. So this is going to be the opposite side of the heart from posterior. So V1 through V4, and typically it's going to be greatest in V2 or V3. Now, having this present and persistent on serial EKGs or continuous monitoring, that this is going to be indicative of a posterior STEMI, and this would warrant a posterior view EKG. And then finally, let's talk about ST depression in the context of ischemia. So this ischemia is actually something that we call subendocardial ischemia. So this basically means that the ischemia does not go the full length of the cardiac muscle, something that we call transmural ischemia. The ischemia is usually just going to be present towards the endocardium, hence the name subendocardial ischemia. Now here with ischemia, we're looking for ST depression in, again, 2 or more contiguous leads, like I said, greater than 0.5 millimeters or half a box. And we can have 2 primary causes of ST depression that are resulting from ischemia: acute coronary syndrome and secondary ischemia. And to note here with these two is we actually can't differentiate between these 2 causes from the EKG alone. We're going to need to evaluate the patient and their presentation to really try and differentiate between them. All right, so when it comes to acute coronary syndrome or ACS, the ST depression that we see in the context of ACS is going to be the result of either a non-occlusive thrombus in the coronary arteries or an occlusive thrombus if the patient happens to have collateral circulation present. So here, what we have is our coronary arteries that have our blood flow going through there. This patient has a plaque that has developed, and that plaque actually ruptures and leads to the formation of a thrombus. Now, with the formation of this thrombus, that it's not going to typically completely block the flow of blood, unless, like we just talked about, they have that collateral circulation. But this is still going to allow some blood and oxygen to reach myocardial tissue. And this is the pathology that we see in unstable angina and NSTEMI. In these cases, T-wave inversion, which I'll actually be talking about next here, may or may not be present. And with this, typically we're either going to see flat or downsloping ST segments. And the deeper and more pronounced that the ST depression is, as well as the more leads that we see it in, that this is generally correlated with the degree of ischemia that's taking place. Now, if these patients also have elevated troponins, then this is going to be a strong indicator of adverse outcomes, and thus these patients would benefit from early invasive management, aka cath lab. That said, these patients actually do not meet the criteria for thrombolysis, as there really was no real mortality benefit seen when they studied this. Now, along with all of this, it's really important to note that with ST depression, that this does not actually localize like ST elevation does. Therefore, ST depression in particular leads really doesn't give us an indication of where the ischemia is taking place, except in that context of reciprocal changes in STEMI, and especially if that patient is having a posterior STEMI. So really, for example here, if you've got an EKG and you see ST depression in leads V3 and V4, this doesn't necessarily mean that the ischemia is taking place in the anterior wall. For secondary ischemia, this is basically where we have ischemia that's not the result of a thrombus. And really, we can see this when there's an imbalance in the oxygen supply and oxygen demand. So on the supply side, if the supply of oxygen is going to be reduced, such as with hypotension, anemia, hypoxemia, or toxins, that this can lead to the imbalance and thus ischemia. Whereas on the demand side, if the oxygen demand is increased, such as with high cardiac output states like sepsis, etc., Addison's disease, hyperthyroidism, or even high catecholamine states like tachycardia and hypertension, we can again see an imbalance leading to ischemia and the ischemic changes. And this can also be the result of sympathetic overload, which we can see with subarachnoid hemorrhage, sepsis, respiratory failure, and overdose. All right, so now on to T-wave inversion. Now that we've talked about the ST depression, we also need to talk about T-wave inversion when it comes to ischemia. Now, when we're thinking about the repolarization event, this makes up our T-wave, and this normally happens in the leftward to inferior and anterior direction. So this means that most of the leads we're going to expect to see normal upright T-waves. Generally, we're not going to worry about inverted T-waves if we see them in leads 3, AVR, and V1, as they're really not uncommon to see here due to the direction that these leads look. This doesn't necessarily mean that they are going to be inverted, but if we do see it here, we're generally not that concerned. And then when looking at leads 1, 2, V5, and V6, that these should always be positive. And we can see inverted T waves in non-ischemic pathologies such as hyperventilation, orthostatic changes, electrolyte abnormalities, as well as some normal variant conditions. That said, when we are looking at ischemia, we can have delayed and abnormal repolarization of the ventricle that's taking place. Thus, this leads to electrical activity going in the wrong direction, leading to the flattening or inversion of T waves that we see on the EKG. So here we're looking for T wave inversion that's at least 1 millimeter deep, so one small box, again present in 2 or more anatomically contiguous leads, and especially if it's not present on a previous EKG. T wave inversion can also precede changes that we see with the ST segment, such as ST depression or elevation, and therefore in the context of signs and symptoms of ischemia, T wave inversion should absolutely be taken very seriously. Alright, and that was our quick review over ST depression and T wave inversion on our 12-lead EKG, which is going to lead us into the next lesson, and which we're going to be talking about the big one, ST elevation and STEMI. Alright, so far we have worked through a ton of lessons in this 12-lead EKG series, and I know this lesson is the big one that most have been waiting for. In this lesson, we're finally going to be talking about the big one, ST elevation, and particularly STEMI on our 12-lead EKG. We have a lot to cover, so let's get started. Of all the things that we can determine from our patient's 12-lead EKG, the identification and subsequent management of patients having an ST elevation myocardial infarction, or STEMI, is probably the most important. This is a life-threatening situation, and without prompt and accurate identification and interventions, the patients will suffer life-changing damage or even death. Even with rapidly identifying and treating these patients, we still may not actually be able to ultimately save them. But being able to recognize this early and start a cascade of treatment and interventions can absolutely save someone's life or reduce the amount of damage that's done to their cardiac muscle. Thus, this lesson is probably going to be arguably one of the most important ones of this series. As I said, we have a lot of information to cover in this lesson, so let's dive into it now. So let's start off talking about the pathophysiology of STEMI and what exactly is happening when a patient is having a STEMI. So if you remember from the last lesson, which I'll link to up above here, we talked about what was happening with blood flow in patients with ST depression having an NSTEMI. Well, typically we have a similar ACS process that's happening here with STEMI. Again, we have our coronary arteries that are supplying blood flow to all the cardiac muscle cells. Again, we have a plaque that is developed and then subsequently ruptured, causing again that formation of the thrombus. The difference now with STEMI is that this thrombus-plaque combo is now completely obstructing the flow of blood. Any area of the heart that is downstream or distal to this obstruction is now no longer receiving any blood flow and thus no oxygen. Now, we can have other causes that are not ACS-related causes, though ACS is certainly the vast majority of these etiologies. Some other possible causes could be coronary embolism, coronary dissection, or coronary vasospasm. Again, these conditions, if they occlude or cause a situation in which blood flow is no longer continuing to flow to the coronary artery, then myocardial infarction would be taking place. Again, these are a small number of cases when compared to the classic ACS that I just described above. So when this happens with our patients, the area of myocardial tissue that's perfused distally to the obstruction is now without oxygen and becomes damaged and quickly will begin to die. So this leads to large areas of injury and thus the ST elevation that we see on our EKG, and then eventually the necrosis and cell death will create that electrically inactive tissue that we talked about in that AMI intro lesson. Again, I'll link to that up above, giving us the quote-unquote window through the heart and producing those pathologic Q waves. Now, this injury and infarction is what we call transmural, or going the full length of the cardiac tissue. This large area of myocardial tissue does not depolarize properly, leaving this tissue electrically positive, giving us that classic ST elevation that we see on EKG. If we see this ST elevation greater than 1 millimeter, so one small box, in any leads except for V2 and V3, and in 2 or more contiguous leads, then this is our criteria for STEMI. Commonly, we can see some physiologically normal ST elevation in V2 and V3, therefore criteria in these leads is a little bit more involved. Basically, if our patient is a male patient greater than 40 years old, then we're looking for greater than 2 millimeters or 2 small boxes. If it's a male less than 40 years old, we need greater than 2.5 millimeters or 2.5 small boxes. And for women of any age, we're looking to see greater than 1.5 millimeters or 1.5 small boxes. And all of this is happening fairly quickly. The longer the time without blood flow and oxygen, the more damage that takes place, and ultimately the more of the heart that dies. The more of this that takes place, the more long-term complications that will result, including decreased function of the heart failure, and if large enough, can lead to death. Therefore, just as with strokes, time is important. Time is muscle. The more time it takes to reestablish perfusion, the more muscle dies. And while it's beyond the scope of this particular lesson and certainly warrants its own future lesson, typically reperfusion will take place in the cath lab, although if one is not readily available or nearby, we can also give a thrombolytic, such as TPA or TNK, to break up that clot and try to reestablish perfusion as well. Now that we have that out of the way, now let's talk about the impact from all of this that we see on our 12-lead EKG. To start the discussion off, we need to revisit a topic we covered in one of the very early lessons in which we talked about contiguous leads. The significance of contiguous leads is that if we think about the position of our various leads and anatomically where they're looking at the heart, certain leads, typically nearby on EKG, are often looking at similar parts of the heart. Therefore, in situations like STEMI, where a large portion of the heart is being impacted, we will see changes on multiple leads looking in similar areas of the heart. This is significant because knowing this and knowing where certain leads are looking, we can determine what part of the heart is impacted and thus have a pretty good idea of the vessel or vessels potentially involved. What this means is we can pretty accurately determine the infarcted regions from the presentation on the 12-lead EKG. So let's bring up an example of a basic 12-lead again. If we look at our leads here and group them together again, we'll show the different contiguous leads that we have. We're going to start off with leads 2, 3, and AVF, and these leads are looking at the inferior portion of the left ventricle. Now leads 1 and AVL are what we consider the high lateral wall. V1 and V2 are our septal leads, looking at the septum, as well as giving us some anterior view. V3 and V4 are what we call our anterior leads, looking at the anterior of the left ventricle. And then finally, V5 and V6 are our lateral leads, looking at the lateral side and the apex of the left ventricle. Now, there's really not many things that I tell you guys that you really need to memorize on this channel, but this chart and these contiguous leads really is something you should commit to memory. It's really not that difficult once you know the pattern, so I really strongly urge you to do so. And one thing to note with our typical 12-lead configuration is that we're not going to have a direct view of either the posterior wall of the left ventricle or the right ventricle. So I will discuss this briefly later in this lesson, but to view each of these, we would need to place some of the leads in different locations. Now, knowing the region of the heart that's being impacted on EKG, we can then combine this with our knowledge of coronary blood flow, again linked to that lesson up above, to have a pretty good idea of the blood vessel or vessels that perfuse that area of the heart. So for instance, if we look at our inferior leads 2, 3, and AVF, most people, so about 90%, are actually perfused by the right coronary artery, while 10% are perfused by the left circumflex. Now for leads 1 and AVL, our high lateral leads, that these are perfused by the left circumflex. Septal leads V1 and V2 are actually perfused by the left anterior descending, or LAD. The anterior leads V3 and V4 are also perfused by the LAD. And then finally, the lateral leads V5 and V6, they can be fed by the distal LAD, the left circumflex, or the right coronary artery. Now, to complicate things more, we don't always just see one area or region that's impacted. We can have multiple areas such as anteroseptal, anterior lateral, or even inferior RV, just to give you a few examples. I will briefly hit on this lesson, but just keep this in mind that when evaluating EKGs, it's not always clean cut with just one region impacted. Alright, and then the last thing I want to cover real quick before we look at our STEMI EKGs is the concept of reciprocal changes. Again, I did briefly mention this in the AMI intro lesson, but I just want to hit on this again here. Due to the size and magnitude of injury that's taking place with STEMI, along with all that abnormal depolarization, that not only will we see the ST elevation in the leads directly viewing them, but the leads that are opposite or looking from the other direction will actually pick up this large electrical activity moving away, thus giving us ST depression. So this is what we refer to as reciprocal changes, and these are commonly seen in patients having STEMI. Okay, now that we have all that information covered and out of the way, let's start to look at some EKGs of STEMIs in different regions of the heart. And to help with the identification, I am going to keep this chart up top kind of showing our infarcted regions. Alright, so let's start off looking at our inferior wall. So remember, this is seen with leads 2, 3, and AVF, and is typically perfused in 90% of people by the RCA, and the other 10% is the circumflex. Our reciprocal changes typically present with ST depression in the high lateral leads 1 and AVL. So if we take a look at our EKG here, you can see clear ST elevation in leads 2, 3, and AVF, along with those reciprocal changes of ST depression in 1 and AVL. This is our classic inferior wall MI. Now, on the subject of inferior MI, knowing that most people have this region perfused by the RCA, we also would be concerned that the patient would have some RV involvement and could have an RV infarct as well. If the patient is having an RV infarction and the RV is weakened, remember that the right ventricle is very preload dependent. The right atrium helps to push the blood flow forward to fill the right ventricle. This process is still primarily driven by venous return. Giving a vasodilator such as nitroglycerin or even morphine could significantly impact this preload and could have significant effects on your patient's hemodynamics and blood pressure. So I've actually seen patients with very good blood pressures that actually quickly plummet after being given sublingual nitro, so it's definitely something to be aware of and to evaluate when you have an inferior MI. So if you do identify an inferior STEMI, before you consider giving nitro for chest pain, you really should get a right-sided 12-lead EKG. To do this, it's pretty simple. We actually keep our limb leads where they are, and what we do with our precordial V leads is we do a mirror image on the patient's chest. What this means is that V1 is now going to be the patient's left sternal border, 4th intercostal space. V2 is now going to be on the right sternal border, 4th intercostal space. V4, we are going to have on the patient's right side, midclavicular line, so that nipple line, 5th intercostal space. V6 is again along that mid-axillary line, 5th intercostal space, on the same horizontal plane as V4. And then V3, we want to put kind of diagonally in between V2 and V4. And then V5 is going to be in the middle of V4 and V6, again along that horizontal plane. So this is going to give us a view of the right ventricle and really help us identify any RV involvement and determine whether the patient should be considered for sublingual nitro or whether we also want to be concerned with like morphine administration as well. Alright, so now let's take a look at an anterior wall MI. So remember that these are leads V3 and V4, and this region is going to be perfused by the LAD. So reciprocal changes are not going to be seen as they would actually show up posteriorly, which, like I mentioned, we don't have a view of with our traditional 12-lead setup. Now, a true isolated anterior wall MI is actually pretty rare. And so this is actually going to segue into a concept that I mentioned earlier, talking about multiple regions being impacted. Oftentimes when we see an anterior wall MI, it's going to be combined with a septal wall MI, something we call anterioseptal involving V1 through V4, as well as extending into the lateral wall, so an anteroseptal with lateral extension, which we'd also see in V5 and V6, as well as potentially in 1 and AVL. So here's an example of such an EKG. In this example, we have a lot going on here. You should pretty easily be able to see the ST elevation meeting all criteria in leads V2, V3, V4, and V5. But if you look at V1, you can also see ST elevation there, and V6 is a little harder to see, but especially if we look at the last one here, we can see the ST elevation as well. So seeing all these areas of ST elevation, we have it in our septal region, our anterior region, as well as that lateral apex region. In this example, we don't see any ST elevation in our high lateral leads, so 1 in AVL, but we do see the reciprocal changes in 2, 3, and AVF. So given the rarity of an isolated anterior MI, here's actually an example of the closest I could find to that. In this example, we definitely have ST elevation in the anterior leads V3 and V4, but hopefully you also see the ST elevation in V2 and V5. So V2 being septal and V5 being lateral. So this really isn't a true isolated anterior MI. All right, now let's talk about the lateral wall. So here we would see our ST elevation in 1 and AVL being our high lateral, as well as V5 and V6 being our lateral or apical. So the left circumflex feeds the high lateral, and for the lateral apical region, this can be any of the three, so LAD, circumflex, or RCA. Reciprocal changes from the high lateral region are seen in the inferior leads, so 2, 3, and AVF. A lateral wall MI can occur by itself, but it's also commonly seen in combination with other regions such as anterolateral, anteroseptal, with lateral extension, as well as inferolateral, just to name a few. So in this example here, we can see clear ST elevation in leads 1 and AVL, but also V5 as well as probable elevation in V6. We do have our classic reciprocal changes in the inferior leads, 2, 3, and AVF, but we also see some ST depression in the anteroseptal leads, V1 through V3. These could be reciprocal changes, so maybe think posterior MI in left-dominated patients, or ischemia in those regions as well. All right, and so speaking of posterior MI, as I mentioned, this region is actually one that we don't have a direct view of with our typical 12-lead EKG. That said, we do have a good view of where our reciprocal changes would be. So given a posterior MI, we would expect to see reciprocal changes in the anterior and septal leads, so V1 through V4, typically seeing this greatest in either V2 or V3. If you see this on an EKG, you should be suspicious of a posterior MI and get a posterior view 12-lead EKG. So again, this is also pretty simple to do. And to do this, basically you're just going to take leads V4, V5, and V6 and move them posteriorly, giving us what we call V7, V8, and V9. To place these, V8 is going to be mid-scapular line, the fifth intercostal space, with us then placing V7 on the patient's left along the axillary line, same fifth intercostal space and same horizontal plane as V8, and then V9 is going to be placed to the right of V8 along the spinal border, again fifth intercostal space, same horizontal plane as the other two. So this is going to give us a view of the posterior of the heart with those leads V7 through V9, and thus we'd be able to actually see ST elevation in these leads if a posterior MI was present. Now also of note, posterior wall MIs are commonly seen combined with inferior as well as RV infarcts. So as an example of just this, here's an EKG with high suspicion for a posterior wall MI. You'll note the deep ST depression in V2 as well as depression in V1. It looks like some in V3 as well. Along with that, we also see ST elevation in leads 2, 3, and AVF, with some reciprocal depression in AVL, indicating inferior wall MI, as well as some lateral involvement with elevation in V6, and looks like some in V5 as well. But given the anterior ST depression, especially the magnitude of it in V2, we would definitely want to get a posterior view to check for posterior wall involvement. All right, and then finally, the last thing I want to cover quickly here is left bundle branch block. So left bundle branch block holds a special place when it comes to MI. So first, it can complicate the recognition of STEMI, as a left bundle branch block can produce ST elevation and T-wave changes that are pathologically normal for these patients. That can either give the false impression of a STEMI, or actually mask a STEMI that's taking place. That said, patients with left bundle branch block can still have MIs, which is something I'll actually be diving into further in the next lesson. But in addition to that, a new left bundle branch block, especially in the presence of signs and symptoms of ACS and chest pain, that we consider this a sign of STEMI. So a study actually looked at this and took patients with new left bundle branch block and chest pain to cath lab and often found a complete occlusion. Sometimes, though, we don't always have a previous EKG to compare to, so when in doubt, if the patient presents like an MI with a left bundle branch block, we should consider it as such. We can also use something called Sgarbossa's criteria, which I am going to be discussing in the next and final lesson of this series to evaluate for acute STEMI in the presence of left bundle branch block. Alright, well, we covered a lot of information in this lesson, and this was a lot of really important information, as being able to identify acute myocardial infarction on EKG is probably one of the most important things to be able to do. Hopefully I was able to present this well and that you have a better understanding of what to look for when you're evaluating your patient's 12-lead EKG. Alright, you guys, we are getting so close to finishing up this amazing 12-lead EKG series. The last lesson we talked about ST elevation, and specifically when it relates to AMI. But we can also see ST elevation for other reasons than an MI, and it's important to recognize these. So in this lesson here, we're going to talk about our STEMI Mimics. Alright, and for this lesson, you guys, please forgive me for my voice. I'm just getting over being sick here, but I wasn't able to get this lesson out last week like I wanted to, but I'm ready to get this 12-lead EKG series just about wrapped up. So while it's very important to be able to recognize and act quickly when your patient is having an MI, unfortunately our patients can also present in other ways, including having chest pain and even having ST elevation on our 12-lead EKG, and it not be caused by an MI. In fact, the majority of ST elevation that we see on our 12-lead is actually not caused by STEMI. Again, if it is a STEMI, it's important to recognize this quickly and to act, as time is muscle here. Therefore, when we see ST elevation on our patient's EKG, we often react quickly to this. We also need to ensure that this is a true STEMI that we're seeing. Again, when in doubt, treat it as such, but there are a group of conditions that can produce ST elevation on EKG that are not the result of an infarction. Some of them still do require emergent or urgent intervention, but then there are some that don't require anything and actually are quote-unquote normal for our patient. We call this group of conditions our STEMI Mimics because they do just that. So that's exactly what we're going to talk about in this lesson here. So before we get into talking about these different conditions, just know that in this lesson I'm going to go quickly through each of these common STEMI mimics. In reality, several of these really warrant their own dedicated future lesson, although not necessarily a part of this 12-lead EKG series. I do have several of them on my to-do list to get to in the future, but I do encourage you to learn more about these to further your own understanding. So again, let's hit real quickly on our ST elevation. And again, I've already covered measuring ST segment and the concepts of ST depression and ST elevation in the past 4 lessons. Here though, I do want to reiterate that we ideally want to compare our ST segment to our TP segment when possible. You'll see here in a bit examples of why, but there are times we can actually have depressed PR segment, which can give the appearance of ST elevation if we're using this as our reference when it's not actually present. Now again, this may not always be possible to use this TP segment, especially with patients with tachycardias, but if you can, this is what you should be using. Now, one common thing that we see when we're looking at all of these ST mimics is that the ST elevation that we're going to see with these is what we call a concave shape. So to identify this, if you draw a straight line from the J point to the top of the T wave, you'll see, like with this example here, where the ST segment is below the line. This is what we call concave. If we draw this line and the ST segment is above, like we see here, this is what we call convex, as well as we can also commonly have flat ST segments as well. If we see flat or convex, that this is most likely a STEMI. Now, if we see concave ST elevation, we still could have a STEMI, but it's more likely we have one of these STEMI mimics. But again, don't discount STEMI if that's how the patient is presenting. And so this actually leads perfectly into the next point that I'm going to make is that remember, with each 12-lead EKG that we perform, there's a real patient associated with that EKG. Now this seems obvious, but I mention this because remember that we want to correlate what we're seeing on the 12-lead to our patient that is in front of us. Our physical assessment of the actual patient can tell us a lot, and we need to remember to take all that into consideration when we're evaluating anything going on with our patient's EKG, especially ST elevation. I'll dive a little further into this with these mimics when I talk about them. And then finally, for the beginning part here, I want to share a quick mnemonic to hopefully help you remember some of the causes of ST elevation, and that is going to be the mnemonic elevation. So to start off with the first E, that this is for electrolytes. And here we're really thinking about potassium and hyperkalemia. For the L, this is for our left bundle branch block, although we can also see the same with right bundle branch block as well. The next E is going to be for electricity. And this is to help you remember both early repolarization as well as pacemakers, specifically in patients who are being ventricularly paced. Next, for the V, this is going to be ventricular hypertrophy, pretty self-explanatory. Then for the A, this is going to be aggravation. And this is a way to help you remember irritation or inflammation of the pericardium, aka pericarditis. Now for the T, this is going to be for thrombus. And here, primarily we're talking about pulmonary embolism or PE, but this could also be a coronary thrombus. And then for I, this is going to be injury. And this could be from infarction, although cardiac contusion can also cause this. Then for the O, this is going to be the Osborn waves. And these Osborn waves, or sometimes called J waves, that they can be seen particularly in cases of severe hypothermia. And then finally for the N, this is going to be non-occlusive vasospasm. And here we have a coronary vessel that is spasming and can temporarily cut off blood flow, giving us the appearance of an obstructive occlusion, but it's really transient in nature. So I'm not going to hit on quite all of these, and I am going to cover them out of order, really to kind of help group together like concepts, but hopefully this will help you to remember all of them. All right, so let's start off first with a quick and easy one, Osborn waves or J waves. So like I said, these are usually associated with extreme causes of hypothermia, so here think temperatures less than 30 degrees Celsius. We can though also see them, although rarer, in hypercalcemia, ischemia, left ventricular hypertrophy, Takotsubo cardiomyopathy, early repolarization, Brugada's syndrome, severe myocarditis, or in some causes of acute intracranial injury. Essentially, the Osborn wave or J wave is a deflection that we can see at the J point following the QRS complex. So here's an example of Osborn waves in a case of hypothermia. Now, sometimes the Osborn waves can be subtle, like we actually see in leads 2 and 3, and if that's all we see, this can actually be more associated with less severe hypothermia. So keep this in mind that Osborn wave size is going to be proportional to the degree of hypothermia. But if we look at our precordial leads V4, V5, and V6, we can see much more obvious Osborn waves. And note that this can produce ST elevation that we see, but here we're seeing that concave shape if we draw that straight line from the J point to the top of the T wave. All right, now let's move on and talk about benign early repolarization. And this can be one of the most confusing ones to identify and differentiate from STEMI. So similar to Osborn waves, with early repol, we're actually going to see something called notch J points that really aren't as pronounced waves like we see with the Osborn waves, but you will see something kind of similar. The morphology of the concave ST segment and the lack of any reciprocal changes is going to be key with this one, although we often will see this with our anterior leads, which we would not expect to see reciprocal changes because those would be happening posteriorly. So here's an example of early repolarization. So you can see obvious ST elevation in leads V3, V4, and V5. You also note the notch J point in those leads. And then of course, if we draw a straight line, we'll also note the concave ST elevation. Another thing that really is inherent with the name early repolarization is that the repolarization is happening sooner, and thus we can see the T wave getting closer to the QRS complex like we're seeing here. So this can be confused for an acute anterior STEMI, but with those points noted above, along with the fact that our lead 2, which we also see this pattern without any contiguous leads reflecting this, as well as no reciprocal changes in our lateral leads, that this can really help us differentiate this as early repolarization. Now, Dr. Smith at the ECG blog has really put together a formula that you can plug in values for your QTC, your R wave amplitude in V4, your QRS amplitude, so both your R wave and your S wave in V2, and measured ST elevation, and get a value that can help differentiate early repolarization from acute anterior STEMI. I'll link to his blog with the formula in the description down below, and on there he also has a link to a free app that you can use for this calculation, so just another tool in your toolkit. Alright, so before moving on and talking about the next few pathologies, it's really helpful to have an understanding of a concept that we call the rule of appropriate T-wave discordance. So you're probably thinking, what the heck is he talking about? So, in cases where we have abnormal depolarization, we're often going to see abnormal repolarization. So what this means is that we'd expect to see the T wave going in the opposite direction of the predominant either R wave or S wave. So if our predominant wave is positive, we'd expect to see a negative T wave and vice versa. Along with that, the J point is often going to get dragged in the direction of this T wave, giving us the impression of either ST depression or ST elevation. So as you can see here, we have an example of a bundle branch block. But in the first example, the S wave is actually our predominant negative deflection, and thus due to the rule of appropriate T wave discordance, we see the T wave going the opposite direction, which is positive, which then drags this J point up and produces a ST segment elevation. Now, in the other example we have here, the positive R wave is the predominant wave, and thus the appropriate T wave discordance would be the negative T wave that we see here, again dragging this J point down and giving us ST depression. So knowing this appropriate T wave discordance, if we had this predominantly positive R wave and we saw ST elevation, that this would actually be concerning here for an MI. And of course, patients who do have these polarization abnormalities can still have MIs, and this can actually make this more difficult to recognize. But we do have a rule that we call Sgarbossa's criteria that we can use to identify abnormal ST elevation in these cases, which I'm actually going to cover in the next and last lesson of the series. Alright, so moving right along, let's talk about left ventricular hypertrophy. But with left ventricular hypertrophy, we have an enlarged and/or thickened left ventricle, giving us the high voltage we see on EKG. Along with that, as things progress, we can begin to see depolarization abnormalities arise, which can lead to something that we call the strain pattern. This strain pattern results in T-wave discordance, and thus we can see associated ST depression and ST elevation. So in this example here, you can definitely see the high voltage in many of these precordial leads based on the massive size of the QRS complexes. We can also see T-wave discordance, especially with V1, V2, and V3 here, where we have the predominantly negative S wave, and thus the positive T wave and associated ST elevation, as well as in V5 and V6, where we have the predominantly positive R wave with the negative T wave and thus ST depression. Now with this ST elevation that we see, again, if we draw our line, we see that we have the concave shape. Now moving on to our bundle branch blocks, but by their very nature, these are depolarization abnormalities, and with such, we'd expect to see our T-wave discordance. So in another example here we particularly have a left bundle branch block, which we can tell with the wide QRS complexes and the negatively predominant S wave in V1. Again, in V1 through V3, we see the T-wave discordance with the associated ST elevation, and while harder to see in our lateral leads V5 and V6, if we actually look at our high lateral leads, 1 in AVL, we definitely see a dominant positive R wave with negative T wave discordance, and thus ST depression here. Again, we see the same concave shape to our ST elevation here, and then given that we see ST elevation in our anterior septal leads, we wouldn't expect to see reciprocal changes in high lateral, and thus this appears to be normal changes seen with bundle branch blocks. And this morphology and presentation is also going to be the same that we expect to see with our ventricularly paced rhythm, with the exception being that we would also see pacer spikes preceding the QRS complex. Alright, next we're going to talk about our pulmonary embolism or PEs. And particularly massive PEs can lead to ST elevation changes on our 12-lead EKG. So let me go ahead and put up an example on screen while we talk about this one. So in this example here, we actually see ST elevation in V1, V2, V3, and V4, as well as AVR and AVF. Now this would actually be an odd pattern when we think about our contiguous leads. Another big thing to note here is that we have opposite T-wave progression in our precordial leads. Here we have positive waves in our right precordial leads, specifically V1 and V2, and then we actually have negative waves in our left precordial leads, V4, V5, and V6, which is going to be opposite of what we'd expect. Also, if you look at lead 1, this is normally positive, that here we have a large negative S wave. And so I did cover cardiac access in a previous lesson, but looking at this, we conclude that we have a rightward access. This is important as a STEMI is not going to cause a rightward shift in the axis. The two main things that would produce a right axis deviation and ST elevation would be hyperkalemia and acute pulmonary hypertension, think PE here. So now I will cover hyperkalemia in just a minute here, but we don't have peak T waves, so after correlating with our patient's signs and symptoms, we can conclude that this is probably from a PE, and then we can use further tools like a CT or an echo to identify this. Now this EKG and the tracing that we're getting isn't the greatest example, especially when we're looking at our ST segment morphology, but you can kind of see in V2 as well as V4 that concave ST segment shape. Alright, so on to the next one. We just mentioned this, so let's go ahead and talk about hyperkalemia now. So hyperkalemia can produce ST elevation that can mimic STEMI. So in our example here, we can see clear ST elevation in leads V1, V2, and V3. So is this an anterior septo-STEMI? Well, hopefully the T waves stand out for you here. And in many of the leads, we see these large, narrow peak T waves, especially V2, V3, and V4. And this is going to be classic hyperkalemia, and thus the ST elevation was actually a result of this. And also note that we do still have that concave ST elevation. And then as a quick example of a more extreme hyperkalemia here, we actually see widening of our QRS complexes, as well as we have what appears to be right axis deviation, especially when we see that large negative S wave in lead 1. Now we did just talk about this with PE, but in this example we do have our classic tall, narrow peak T waves in V2, V3, and V4. And so that's how we can differentiate the hyperkalemia from our PE here. Alright, and then finally for the last of our STEMI mimics, we're going to talk about probably the hardest one sometimes to differentiate from STEMI, and that's going to be pericarditis. Oftentimes, pericarditis is actually misdiagnosed as STEMI, as well as STEMI being misdiagnosed as pericarditis. Now, the discussion of pericarditis definitely warrants its own future lesson, but essentially here we have inflammation and irritation of the pericardial sac that's surrounding the heart. So pericarditis can actually lead to profound ST elevation across our EKG, and in later stages T-wave inversion, which can complicate this diagnosis. So how do we differentiate between pericarditis and STEMI? Well, a lot of times you're going to see the ST elevation across the EKG, and you might be thinking pericarditis, but the very first thing we need to do is actually look for some specific STEMI inclusion criteria. So first we want to do is we want to ignore V1 and AVR, and then we want to look at the rest of the EKG for any ST depression. If it's present, we have a STEMI. Next, if we have ST elevation that's present in leads 2 and 3, if the ST elevation is greater in lead 3 compared to lead 2, then again, we have a STEMI. And then next, we want to look at the morphology of the ST elevation. If we have convex or flat ST elevation, we have a STEMI. And then finally, if we have on our EKG any known acutely new Q waves, again, we have a STEMI. Be careful with this one though, as we need to make sure that they are new and acute. Now, once we've excluded any of the above cases, we can actually start to look for any signs of pericarditis. And remember to listen to the patient and the signs and symptoms that they're presenting with, as these things such as friction rub or chest pain that's relieved by leaning forward is really going to help you to differentiate pericarditis. With pericarditis, we're typically going to see a concave ST elevation globally across the EKG. So here we're seeing ST elevation going across reciprocal leads where we wouldn't normally see all this ST elevation. We can also see PR depression with pericarditis in multiple leads. Now this can be an indicator as well, although it is more associated with viral pericarditis. And that being said, patients with STEMIs still can have PR depression sometimes, so this doesn't necessarily mean you're having pericarditis if you see this. Now, along the lines with PR depression, we also can see something that we call Spodek sign, which is a downsloping, almost stepwise decreasing in amplitude or height of our ST segment, TP segment, and PR segments. All right, so let's take a look at an EKG here. So on this EKG, you can see we've got ST elevation all over the place. But before we start considering pericarditis, we need to look for any of those STEMI inclusion criteria. So we want to start off looking for ST depression, which we do see it in AVR and V1, but those are leads that we can expect to see it sometimes, and so like I said, we need to ignore those. Looking around the rest of the EKG, we actually don't see any other ST depression here. Alright, so next, do we have ST elevation in lead 3 that's greater than lead 2? Well, no, we actually don't have any in lead 3, so that excludes that. Now looking at our ST elevation, do we see any flat or convex ST elevation? Nope, they're all concave. If we draw the line, we can see that clearly here. And then here we don't have any Q waves, so we're not going to do that, nor do we have a previous EKG to compare to here. Alright, so now looking at the rest of the EKG, like I said, we clearly see the ST elevation across multiple leads and spanning across reciprocal changes. We see it in 1, 2, AVL, V2, V3, V4, V5, and V6. And again, it's all concave shaped. Then do we see any PR depression? Well, yeah, actually in leads 1 and lead 2, and it's hard to tell, but possibly in AVF as well. And then also maybe in V2, V3, and V4. Now in this example, it's not as obvious, but we do have the Spodek sign with the downsloping ST, TP, PR segments, especially when we're looking at our precordial leads. You can see that downward slope, so that starting high and then coming down lower as we work our way from the ST segment to the PR segment. And so with all of this that we just discussed and that we see here, we can conclude that we're probably looking at a case of pericarditis. And then lastly, I want to put up one more example EKG just to show you a really great example of this Spodek sign. I'm not going to go through all the steps here, but hopefully you can see it's pretty clear. We've got ST elevation all over the place here. And in several leads, we can really see our Spodek sign. But especially if we look at leads 2, 3, and AVF, we have a very clear downsloping or stepwise drop from ST to TP to PR segments. All right, well, we covered a lot of different pathologies and morphologies in this lesson, all of which can produce ST elevation and thus mimic our STEMI on EKG. It's important to be able to recognize these and to be able to differentiate them from an acute MI, as we want to make sure we can diagnose a STEMI accurately and promptly, but also to prevent misdiagnosis as well. All right, you guys, we have just about finally finished this incredible 12-lead EKG series. This is the last and final lesson of this series. In the previous lesson, we talked about our STEMI Mimics, but if you remember, I mentioned with some of these depolarization abnormalities giving us the STEMI Mimics, that these patients can still also have AMIs, making it more difficult to identify. Well, one such method to help us do just that is called Sgarbossa's criteria, and we'll discuss that in this lesson now. Okay, this has been one heck of a journey through so many aspects of our 12-lead EKG interpretation. We've covered a ton of information over the last 14 lessons. Wow, I can't even believe that number. This is by far the longest series to date. In this lesson, we need to cover one last thing to round out the topics that we covered in this series. And remember that there are so many more things that we didn't cover here, as well as some things that you can learn so much more about, so I do truly encourage you to continue to learn more on your own about this complex subject. That said, and like I mentioned in the intro, we need to talk about the final piece of being able to still identify acute myocardial infarction in patients who have depolarization abnormalities. The way that we can do this is with a set of criteria that we call Sgarbossa's criteria. So let's start off with a little background and quick overview of what this is. So Sgarbossa's criteria is a set of rules that were really identified in 1996 to help identify AMI patients who have a left bundle branch block. So Dr. Elena Sgarbossa and her team were really looking at data from a famous study of that time, looking at the use of thrombolytics to help rule in or rule out patients for AMI. They took a look at a subset of the patients who had a left bundle branch block and tried to find a pattern in those who were ruled in for AMI as opposed to those who were ruled out. They ended up finding a pattern and created a set of rules that were really a game changer for being able to identify AMI in these patients. Because prior to that, the school of thought was that in a patient who has a left bundle branch block that you can't possibly identify them having a STEMI. So for Sgarbossa's criteria, there are 3 criteria, which I'll be covering in just a bit here, that if any of them are met, that this can be specific for STEMI, and the more criteria that's present, the greater the sensitivity. Later on, Dr. Smith, again the same Dr. Smith from the ECG blog I mentioned last lesson, came along and made a slight modification, something that we refer to as Smith's modification to Sgarbossa's criteria, which Dr. Sgarbossa herself later endorsed. This modification helped to improve the accuracy of these criteria. Now, one thing to note is that this criterion was identified in patients with left bundle branch block. Subsequently, it was determined that this can also be used in patients with ventricularly paced rhythms, however, it is less specific. There's also been some speculation about this being beneficial in patients with left ventricular hypertrophy with a strain pattern. Again, another STEMI mimic we talked about in that last lesson. But the evidence isn't as clear on this one, and even Dr. Smith has commented about it, stating that it really needs further investigation before determining the accuracy and if any other modifications are necessary. So the important takeaway is that in patients with left bundle branch block and even patients with ventricularly paced rhythms, that we have a set of criteria that we can use to evaluate these patients and help to identify STEMI. That said, just because these criteria are not present does not mean you can rule out STEMI. Alright, so now let's cover what criteria are included in Sgarbossa's criteria. I'm actually going to be discussing Smith's modification to Sgarbossa's criteria here, but before we begin, remember that in left bundle branch block, from our previous discussion on those STEMI mimics, that we have something we call the rule of appropriate T-wave discordance. We expect to see the T wave in the opposite direction of the predominant R or S wave, as well as the J point pulled in the direction of the T wave, giving us the appearance of either ST depression or ST elevation. Now, knowing this, if we see something that we call concordant ST elevation or depression, that this can actually be an indicator of STEMI. And here, concordant means that we have ST elevation or depression that's going the same direction as the predominant R or S wave. Again, I'll show examples of that here in just a minute to help make this point make more sense for you. Alright, so on to the criteria. Like I said, we have 3 criteria that we are evaluating. We're looking for concordant ST elevation, concordant ST depression, and proportionally excessive discordant ST elevation. So starting off with the concordant ST elevation. For this, we would have a predominantly positive R wave, as you can see in this example here, and instead of the J point being pulled towards the negative T wave giving us ST depression, we actually have ST elevation here that's concordant, so in the same direction with that R wave. If we have at least 1 millimeter of concordant ST elevation and at least 1 lead anywhere on the EKG, that this would indicate STEMI, and this criterion here actually has the greatest specificity. Alright, so next we want to look for any concordant ST depression. So here we have a predominantly negative S wave, such as in the example here. And again, we'd expect to see the J point discordant to the S wave and pulled towards the positive T wave, giving us ST elevation. But now we see that we actually have concordant ST depression here. If this concordant ST depression is present in at least one of the leads in V1 through V3, and it's at least 1 millimeter deep, then this is another indicator for STEMI. All right, and then finally, for our last criteria, we need to evaluate the proportionality of the size of the ST elevation when compared to the size or the amplitude of the negative S wave. And this third criteria is actually the one that Smith modified from the original Sgarbossa's criteria, which previously didn't compare the size of the S wave and the ST elevation, and it just looked for a fixed size of ST elevation. Now for this one, what we want to do is measure the amplitude of the ST elevation and then compare that to the amplitude of the negative S wave. If the ST elevation is greater than or equal to 25% of the amplitude of the depth of the S wave, and this is present in at least one lead anywhere on the EKG, that this is also an indicator of STEMI. So those are the three criteria, and if any of these three criteria are present, then we would conclude that this patient is having a STEMI and treat it just like any other STEMI with our management, cath lab activation, etc. Remember though that just because these criteria are not present, it doesn't necessarily mean we can say that this is not a STEMI. Alright, and so finally, now that we've covered what the criteria are, let's take a look at a great example of an EKG that will actually show us all three of these criteria present. So in this example, let's start off looking for any concordant ST elevation. Do you see any present here? Hopefully you can see it in three different leads. If you look at our lateral and high lateral leads, you can actually see concordant ST elevation in leads 1, AVL, and V5, all at least 1 millimeter in height. Now with these predominantly positive R waves, remember, due to that rule of appropriate T-wave discordance, we'd expect to see negative T waves and ST depression, but instead here we have that ST elevation. And seeing this in even just one lead, we could say that this patient is having a STEMI. Alright, so next, let's look and see if there's any concordant ST depression. Do you see any here? Well, hopefully you're able to spot the two easy ones to identify in our inferior leads, lead 3 and AVF. As you can see, we have predominantly negative S waves, so again, we'd expect to see positive T waves, which we do have here and here, as well as normally we'd expect ST elevation. But instead, here we have ST depression. This is that concordant ST depression. Now, in this example here, the concordant ST depression we see is not present in V1 through V3. Therefore, this example wouldn't be an indicator of STEMI, and what we're probably actually seeing is more in the context of reciprocal changes in the inferior leads due to a high lateral STEMI. But this does serve as a good example of what this concordant ST depression is going to look like. And then finally, we want to look for any disproportionately large ST elevation when we're comparing that to the size or the amplitude of a negative S wave. Do you see anything on here that stands out to you? With this example, it's a little hard to measure since the small boxes are not as clear, but let's look at V4 here to start. Hopefully this one really stands out. If we measure our S wave, I'm guessing that this is about 7 millimeters deep. Looking at our ST elevation, if we guesstimate our J point to be right about here, we have about 4 millimeters of height. So if we divide our ST elevation of 4 by our S wave amplitude of 7, we get 57%, which is way above our criteria of greater than or equal to 25% in at least any one lead. So at this point, we can say that this patient is having a STEMI. Now, V1 through V3 are all pretty close to 25%, but again, it's hard to tell for sure in this example. When you have the actual EKG in front of you, you'll be able to easily read the markings and make your actual measurements. Alright, well hopefully that example helped to show you the 3 different criteria on an actual 12-lead EKG and what you'd expect to see. The only difference being that concordant ST depression, in order to call it a STEMI, we want to see that in either V1, V2, or V3. Now, it certainly can and will get more difficult to read with some EKGs, but if you take your time and go through your steps with evaluating your EKGs, you'll get better and better at recognizing these different patterns. And this goes not only for Sgarbossa's criteria, but for all of the different things that we've discussed over the course of this series. The most important thing with all this is for you to go out and put into practice and really get your reps in looking at patients' EKGs constantly and go through the steps of your interpretation and really working to identify the various aspects that we've discussed. It takes time and it takes repetition, but eventually these will become more natural and quicker for you to do. I truly hope that the discussion of all of this over the past many lessons is really going to help to guide you down the path of being able to read and interpret your patient's 12-lead EKGs. So I hope that you guys found this information useful. If you did, please leave me a like on the video down below. It really helps YouTube know to show this video to other people out there, as well as leave me a comment down below. I love reading the comments that you guys leave, and I try to respond to as many people as I can. Make sure you subscribe to this channel if you haven't already, and a special shout out to the awesome YouTube and Patreon members out there. The support that you're willing to show me and this channel is truly appreciated, so thank you guys so very much. If you'd be interested in showing additional support for this channel, you can find links to both the YouTube and Patreon membership down below. Head on over there and check out some of the perks that you guys get for doing just that, as well as check out some of the links to other nursing gear, as well as some awesome t-shirt designs I have down there as well. Make sure you guys stay tuned for the next lesson that I release. Otherwise, in the meantime, here's a couple awesome lessons I'm going to link to right here. As always, thank you guys so much for watching. Have a great day.